and I am delighted to welcome everybody to our annual Kidney Cancer Patient and Caregiver Education Symposium. I'm not sure what anniversary this is of this symposium, but our attendance has grown every year, and it's thanks to folks like you who are joining in, as well as our partners, which you can see listed below, including KidneyCAN, the Kidney Cancer Association, and Smart Patients. Just for some host introductions. I've introduced myself. I'm a urologist here at the Fred Hutch Cancer Center and UW, as well as the director of the Surgical Oncology Division. But I would also like to introduce Dr. Scott Tykodi, who I know many who are logging in also know, who is a professor at the Fred Hutch Cancer Center and is also an investigator in the TST division at the Fred Hutch, which is one of our robust research divisions. I'd like to hand it over to Ritu, who's our co-host, to talk about some sort of orders of business for the symposium. But thank you, everyone, again for logging in.
Thank you, John. So this event is being recorded, and a link to the recording will be sent to all in a post-event email a few days after the event. If you have any questions, you can post them using the chat function. If you end up accidentally leaving the Zoom webinar, you can rejoin by just clicking the link that was sent to you in an email. And post-event, we'll be sharing a link to the feedback form. Please take a moment to fill that. We really use those to plan our future events.
Sorry, I was unsuccessfully trying to unmute myself, and the slides were making it very difficult. Um, uh, Definitely please take the time to use the feedback forms. We really do look carefully at all the comments, and oftentimes the subsequent year's agenda directly follows from a lot of the feedback items. At this point, I would like to introduce Dr. Tykodi.
Great. Thank you, John. It's a real pleasure for me to be here. We started this program in 2015. So this is our 12th year of hosting one of these programs for our patients and our caregivers. I'm Scott Tykodi. I'm sure I know many that are in the audience. I'm a provider here at the Fred Hutch campus, specializing in the care of kidney cancer patients and a clinical investigator. And it's a real pleasure to work with John. I know John introduced himself, but just to highlight that John has taken on a leadership role in this calendar year as a senior vice president and director of surgical oncology for the Fred Hutch Cancer Center. So we're really thrilled to have John as one of our core kidney cancer providers and a voice for our patients and our program to now be serving in a senior role at the Cancer Center. So I think it's only going to help us and bring good things to our kidney cancer program. Let's move forward with this year's program. Let me get my info up here. I am thrilled to be able to welcome our first speaker, an outside investigator, Dr. Vincent Xu. Dr. Xu and I overlap. He's a medical oncologist at the Harvard Medical School, where he's assistant professor, and also a member of the Dana-Farber Cancer Institute. The Dana-Farber and the Harvard system is really an extraordinary footprint in the landscape of kidney cancer research and kidney cancer care. It's amazing how many investigators across the country trace their training back to the Dana-Farber program. He has worked in the last couple of years bringing forward a new protein marker as a biomarker for kidney cancer, KIM1, and has presented at numerous national, international meetings on that work. And this morning is going to be talking to us a little bit more broadly, giving an overview of renal cell carcinoma medical treatments and the renal cell carcinoma landscape. So let me turn the program over to Dr. Xu.
Great. Thank you so much for that extremely kind introduction. And just thank you to Dr. Tykodi and Dr. Gore and all the conference organizers for this opportunity to talk about some of the current treatment options for kidney cancer and kind of where that puts us for patients in the treatment landscape. So as Dr. Tykodi kindly introduced, I'm Vincent Xu from the Dana-Farber Cancer Institute. Here are my disclosures. The renal cell carcinoma landscape has been getting bigger over time in the sense that kidney cancer is becoming a more common disease. And this is true in the United States, but it's also true worldwide, with a large fraction of cases also coming from Asia and Europe in recent years. And across these countries, on average, the rate of kidney cancer has been increasing at an incidence of about 2% increase per year. And fortunately, our treatments are also improving, but certainly this is going to mean more and more patients with kidney cancer needing treatment over time. Part of this is environmental, and part of this is probably due to lifestyle changes worldwide, including an increasing incidence of obesity, which is a risk factor for kidney cancer. We know for kidney cancer that localized disease has much better outcomes than distant or metastatic disease, as shown here. Although, as I'll allude to in a bit, this 20% 5-year relative survival for distant metastases is actually quite outdated, despite it being the latest download from the SEER database. And as I'll show in trials, we've actually been doing much, much better than that 20% number in recent years, and hopefully we'll continue to do better. It's important to remember that not all kidney cancers are the same. And for the purposes of this talk, I'm going to focus most of the data on the most common type of kidney cancer, which is clear cell renal cell carcinoma. And this tumor accounts for about 70% or so of all kidney cancers. And this tumor is generally driven by alterations in the VHL gene, which cause a bunch of downstream gene products to behave abnormally, leading to tumor growth. However, there are many other types of kidney cancer, and this is by no means an exhaustive or complete list. This is a very abbreviated list, but here are some of the main subtypes shown. And as time goes on and our scientific understanding of the tumor has improved, we've more and more nuanced our understanding of these subtypes, and the number of subtypes has also been increasing as we discover new ones. And so about 10% of kidney cancers are true papillary kidney cancers, and these have a unique appearance under the microscope and are enriched for c-Met mutations. And another 10%, which we mostly used to call papillary kidney cancer, but really aren't, are tumors that may appear papillary, but actually have genetic alterations such as FH or SDH driving the tumor. And these behave quite differently from regular papillary tumors. Then there are about 5% chromophobe renal cell carcinomas. These on average grow slower than clear cell kidney cancer, but still can metastasize and can be quite tricky to treat if they do metastasize. And then about 5% translocation renal cell carcinoma from translocation type alterations in TFE3 or TFEB. And these tumors tend to happen more frequently in young people and women. So another quite unique subtype. And there are many other subtypes, including renal medullary carcinoma and others that are more rare and are not shown here. So how do we treat kidney cancer? Well, in early stage kidney cancer, direct treatment of the localized tumor is still the mainstay of care. And so if we have a small kidney tumor that needs treatment, maybe not every tiny kidney tumor necessarily needs treatment, but if treatment is needed, the most common standard of care is surgery with either a partial or radical nephrectomy. And if surgery is inconvenient for some reason, ablation or stereotactic radiation can also be options. There are currently no approved neoadjuvant medications for use in kidney cancer. So there are no routine standard of care medicines given before surgery outside of a clinical trial, although certainly that's an interesting area for clinical trials. After surgery, if the risk for recurrence is high enough for a clear cell kidney cancer, there are approved medications to reduce the chance of recurrence. including pembrolizumab and belzutifan, which I'll talk about. And so the short story is, despite really excellent surgical options and advances in local treatments, there still are a significant number of patients with kidney cancer who do need medications in some form or the other. And so what are these medications? These are the last 20 years of FDA approvals for kidney cancer. And looking at the timeline, this has really come in mostly 3 waves of medication approvals as our understanding of the biology of kidney cancer has also improved. And so the first wave of approvals came from these anti-blood vessel type medications, VEGF receptor tyrosine kinase inhibitors mostly, including sorafenib, sunitinib, and other second generation ones that work by blocking VEGF receptor and targeting the tumor blood vessels, among other things. The second wave of approvals came from the availability of immune therapies and more recently immune checkpoint inhibitors, which take the brakes off the immune system and encourage our body's own immune systems to fight the cancer, including nivolumab, nivo-ipi, and other combinations of immunotherapy with other medications. And these combinations still form the backbone for first-line treatment today and are very, very important. And then in the last 3 years, we've started to see a new class of medications come onto the scene. And these are HIF-2 inhibitors. And HIF-2 inhibitors are the first truly clear cell kidney cancer specific medications that target the specific biology of VHL alterations by blocking the HIF-2 protein. These were first approved with belzutifan for metastatic kidney cancer, but now just earlier this year, less than 2 months ago, we've had approval of combination belzutifan plus pembrolizumab for adjuvant therapy to reduce the chance of recurrence. And hopefully many, many more approvals to come. So, we have new drugs. Are these drugs helping patients live longer? And I think it's clear to me the answer is yes. If we look at how long patients live, the median overall survival on first-line metastatic treatments in phase 3 trials, we can see that in the last 20 years, there's a clear trend where with more and more trials coming online, the median survival is getting better over time. And the survival nowadays, if you look at the most recent trials, including Checkmate 9ER and CLEAR, are approaching 55, sometimes even 60 months, close to 60 months or 5 years. And so we are seeing more and more patients live longer, even with metastatic disease. This is not good enough. This is improvement, but hopefully we'll continue to do better. And so, presenting this in another way, what are the tools in our kidney cancer toolbox? Today, we have mostly 4 buckets of tools or 4 components of our toolbox. And it's a bit of an oversimplification because certainly not all the medications in each category are necessarily similar to each other. But roughly speaking, we have a bunch of medications that block cancer blood vessels, the VEGF receptor inhibitors. We have some medications that block the mTOR protein, and these are older medicines, everolimus and temsirolimus, but still occasionally helpful for patients. We have immune system medications, of which the newest are the immune checkpoint inhibitors by boosting the immune system. And then HIF-2 alpha inhibitors, belzutifan is the current only approved one, but there may be others potentially coming soon. What does this mean for patients? Well, I think it's important to remember that just because a medication is available does not mean that medication is going to be the right choice for a particular patient. And so I think it's important to have discussions with your oncologist that even if a choice is recommended per the NCCN guidelines, oftentimes it may not be the right choice for your particular situation. Some of the things that we talk about when we sit down with patients include, what are the goals of treatment? Are we trying to prevent recurrence? Are we trying to cure the cancer? Or are we trying to slow progression and improve quality of life and quantity of life? And depending on the goals, the treatments will be different. What is the likelihood of success? What is the likelihood of side effects, and how bad may the side effects be? Are there other medical conditions that make certain side effects riskier than others? For example, is there uncontrolled type 2 diabetes that would make immune toxicity requiring steroids much higher risk? Or are there existing autoimmune conditions or existing uncontrolled blood pressure that would make certain medications more dangerous than average? And we also consider the biology of tumors. Even though we'll focus mostly on clear cell cancer, different variants of kidney cancer have different sensitivity to each of these drugs. And some cancers are more sensitive, for example, to immunotherapies than others. And we consider the treatment schedule. Some of my patients come and see me and they are commuting from out of state or even internationally, and we have to take into that account if there is a need for an infusion every 3 weeks, for example. Shifting gears a bit, let's get into a little bit of the nuts and bolts, and I'll start with adjuvant therapy. So adjuvant therapy is cancer treatment that's given after surgery to prevent recurrence. So this is given for patients where we don't know of any cancer in the body. All the cancer that we know of has been removed, but we think the risk of recurrence is high enough that we want to tilt the odds by giving some treatment. In other cancer types, sometimes adjuvant therapy includes chemotherapy or radiation after surgery or hormone therapy. But in the case of kidney cancer, adjuvant therapy most commonly means immunotherapy with or without a targeted therapy blocking HIF-2. And of course, we have drugs that are now approved, which is great news for patients. But as always, just because it's approved doesn't mean it's right for every patient. And so always an important question to ask, is it right for you? It's very exciting in the last few years for kidney cancer that after a long period of really kind of many, many negative trials for cancer prevention after surgery, we finally have several positive trials for adjuvant therapy leading to recent approvals. The most important recent positive trial that first came along was Keynote 564, which showed that adjuvant immunotherapy with pembrolizumab for 1 year improved both disease-free survival and overall survival for higher risk patients with kidney cancer of the clear cell type. There were a few other immune therapy trials that didn't turn out positive. And then another trial that was immunotherapy alone, Rampart, recently read out positive. And this showed that the combination immunotherapy of durvalumab plus tremelimumab also improves disease-free survival in kidney cancer. I'll note that the Rampart regimen is not currently approved in any country. The LIGHTSPARK-22 trial was very recently presented and builds on the adjuvant pembrolizumab backbone, showing that adding a second adjuvant medicine further improved disease-free survival. So we'll get into a little bit of the details here, hopefully not too much. Starting with Keynote 564, this was the first immunotherapy to be approved in the post-surgery setting for kidney cancer for prevention of recurrence. This was a very large trial, 1,000 patients, randomized to 1 year of pembrolizumab immunotherapy or placebo for 1 year. And the eligibility is shown here. I'll just say that the eligibility restricts this to patients who have sort of a moderately high chance of recurrence. Disease-free survival, or what we call DFS, was improved on this trial, and the hazard for disease recurrence or death was improved by about 30% for patients who received immunotherapy versus patients who did not. And indeed, this also led to an improvement in overall survival. And so patients live longer. When you consider living longer for any reason, patients lived longer with an improvement in hazard of about 34% compared to placebo. But with all treatments, what are the downsides? Well, one of the main downsides is the possibility of side effects. And side effects indeed happen on immunotherapy. The most common side effects seen were thyroid abnormalities, high or low thyroid levels, which are usually treatable with medications. But there are also some risks of serious side effects, including lung inflammation, pneumonitis, adrenal insufficiency, permanent type 1 diabetes, As you can see, these side effects are not common, but they can be life-threatening and life-changing if they do occur. And overall, about 7% of patients required high-dose steroids to calm down the immune system after treatment. That was very exciting, and it did lead to FDA approval. But I think it's important to keep the perspective that this is still an area that has a lot of room for improvement. And so this was really an excellent perspective that was first given by Dr. Pedro Barada at the GU ASCO meeting a couple of years ago. But when you look at the adjuvant immunotherapy data, the curves, the bottom curve is placebo, the top curve is immunotherapy with pembrolizumab. 52% of patients on this trial were already cured by their surgery. We didn't know who those patients were, but in retrospect, those patients would have been cured no matter what we did. And we wasted their time by giving them immunotherapy, and we possibly caused side effects. 40% of patients would have had cancer recurrence no matter whether they got pembrolizumab or not. And so for those patients, we didn't help them. They got treatment, but we didn't help them. And they may have also had side effects. That space between the two curves, 8% of patients, those 8% out of the total 100% enrolled on the trial are the patients that were cured by the treatment and had the most benefit. And so really the question is, how can we do better? How can we do better for the 52%? And how can we do better for the 40%? Well, the second question was partially addressed by this other trial recently reported, LIGHTSPARK 22. This trial added a second treatment for adjuvant therapy to pembrolizumab. Everyone got pembrolizumab, and half the patients were randomized to also get the HIF-2 inhibitor, this oral medicine, Belzutifan. Again, the primary endpoint was disease-free survival to see if we can improve the chance of progression or death. And this was a positive trial. Again, giving 2 drugs instead of 1 drug further reduced the chance of disease recurrence or death with an improvement in hazard of about 28%. And, this was significant and led to FDA approval of this medication just recently. Overall survival is still pending, and we don't know yet whether this combination will improve survival outcomes. This figure just points out that patients are doing really, really well on this trial, which is good. As you can see, well over 90 to 95% of patients are still alive at 36 to 42 months, which means that patients are not dying, which also means that we're probably not going to get this answer for a very long time, because the longer patients live, the less data we'll have, which of course is what we want. Looking at toxicities, as you might expect, adding more medication adds side effects. This is almost always true. Adding Belzutifan adds side effects, predominantly anemia, which happen in over 80% of patients and can be treated with either erythropoietin or transfusions if needed. Also added fatigue. Patients felt more tired. And what's important to know is that Belzutifan has a rare but serious potential side effect of hypoxia. It can cause patients to have low oxygen levels, which can be quite bothersome for quality of life. And so, like with most things, the increase in efficacy does come with increased side effects. And so what happens for a patient? Is adjuvant therapy right for me? Well, I think we have to, like with all things, be thoughtful. When I sit down with a patient, I have an honest conversation. Is your cancer aggressive enough? What's the actual chance of recurrence? And there are calculators that we can use to estimate the probability of recurrence in 3 years or 5 years. If that probability is high, a 30% decrease in hazard is actually a more benefit compared to someone whose probability of recurrence was already low. And if you decrease that low chance of recurrence by 30%, that actual marginal benefit is going to be less. What else is going on? A patient who's 40 is going to have more years to benefit from a decreased recurrence risk compared to a patient who's 80, 85, 90 or older. And so certainly we also look at not the biologic age necessarily, but the medical age. What else is going on, and are there other medical issues? And then we also are working hard, us and others, to try to find out, can we be smarter about how we pick these patients? In a perfect world, we would only give adjuvant therapy to that 8% of patients in the middle where we know it's going to cure them, and it's not giving too much or giving too little. And some biomarkers are emerging to help us discover how to do this. Just to give one quick example, in one of the negative adjuvant trials, which was iMotion 10, investigating a different adjuvant immunotherapy, we looked at levels of the KIM-1 protein, and it turned out that patients who were KIM-1 high, based on a blood test, had benefit from immunotherapy in the adjuvant setting, whereas patients who were KIM-1 low not only didn't have benefit, but actually looked like they were doing a little bit worse from getting immunotherapy. So there's a chance that we actually hurt those patients. As time goes on and these markers get validated, hopefully they'll make us smarter about treating our patients. So shifting gears, I'm going to move to metastatic kidney cancer. What do we do if the cancer has already spread beyond the kidney and surrounding lymph nodes? So if we look at the NCCN guidelines, currently there are 5 preferred treatment regimens for first-line treatment of metastatic kidney cancer. And most of these regimens are combinations of immunotherapy plus some other therapy, a second immunotherapy or a targeted therapy. In the second line or beyond, if someone has already progressed on prior treatment, it gets more complicated. And oftentimes it's a very individualized decision based on what the patient has already received and what the patient is able to tolerate based on their side effects. Until we get better personalized blood tests, a lot of our decisions initially are still based on a clinical risk score called the IMDC risk score. This has been around for a long time, over 10 to 13 years. And this risk score is quite simple to calculate with 6 points total. You get 0 or 1 based on whether you're having a good performance status, whether it's been less than 1 year since diagnosis, whether you have anemia or high calcium or high neutrophil count or high platelet count. And if you have 0 points, you don't have any of these risk factors, you will have favorable risk. And if you have 1 or more risk factors, you have intermediate or poor risk. And this does help to give some sense of how aggressive the kidney cancer is. When we treat patients, most of the time, and of course, most of the time doesn't mean all the time, but we're often picking one of these 4 combination therapies that are shown in green. All 4 of these combination therapies have shown in randomized phase 3 trials to improve progression-free survival and improve overall survival compared to the old standard of care, which was a medicine called sunitinib. All of these are FDA approved, and all of them have at least some chance, based on the immunotherapy, for producing a lasting long-term response in some patients. And so I would say that, for most patients, these are preferred options. Let's briefly talk about each of them. I'll start with the only combination immunotherapy that's approved for treatment of kidney cancer. This is ipilimumab and nivolumab, 2 immunotherapies given together, both injections, really doubling down on the immune system. And what I want to point out is that this combination doesn't have as high a response rate as combining an immunotherapy with a blood vessel targeting medication. But the advantage for this combination is that some patients do really spectacularly well. And so if you do have a response, there's a chance the response may last many years or even a lifetime in some patients. If you look at the progression-free survival, even going out 96 months, which is 8 years, about a quarter of patients are still alive without progression. And this is despite the fact that this regimen is usually stopped at 2 years after discussion with your oncologist if the treatment is going well. And so these patients alive at 8 years, many of those patients have not been on any cancer treatment for 6 years and doing well. And so that is kind of the home run that we're aiming for these patients. Another way of saying this, if you're having a good response at 2 years, there's an 80% chance you're still having a great response 2 years later. The response rates for combination immunotherapy are higher, actually, in patients with worse risk. And so in favorable risk patients, the response rates are ironically a bit lower, but there's still a subset of patients who have excellent long-term responses. And so, this is more of a nuanced conversation where there's a trade-off between chance of response versus possible durability of response. Like with all treatments, there are side effects. The immunotherapy side effects are more common for ipilimumab and nivolumab compared to if you were getting a single immunotherapy, for example, pembrolizumab in the post-surgery setting. And so, as you can see, 93% of patients had some sort of side effects. And overall, immune side effects are decently common. 30% of patients required high-dose steroids to calm down the immune system. Take-home points. Combination immunotherapy, ipilimumab and nivolumab, has been around now for a while. Longest follow-up. We know patients, a subset, do really, really well for a long time, even off treatment. And some patients have a complete response. Conversely, unfortunately, 20% of patients seem to have no benefit at all from this treatment and grow immediately on the first scan. There is an injectable version, IV, and there's now a subcutaneous version of nivolumab for maintenance, which for some patients can be more convenient, and a 30% chance of significant autoimmune side effects. I'll talk about 3 other first-line treatments, and the 3 other treatments that I'm going to mention are all combinations of one immunotherapy plus one pill, which is a VEGF receptor tyrosine kinase inhibitor, what we call a TKI medication. The common thread for these next 3 treatments is that they all have really quite high response rates and a very, very good chance of immediate cancer control. But they require long-term treatment with an anti-cancer pill, and these pills come with a different set of side effects. So again, nivolumab and cabozantinib improved both progression-free survival and overall survival compared to sunitinib, and the side effects are different. Like with most tyrosine kinase inhibitors, there's a decently high risk of fatigue, diarrhea, hand-foot syndrome on the hands and feet, which can be uncomfortable to walk, for example, mouth sores, decreased appetite, low thyroid. And so, this is really a collection of rather annoying side effects, often requiring dose adjustments. Similarly, pembrolizumab and lenvatinib also similarly showed improved overall survival and progression-free survival with a mostly similar side effect profile with some small nuances that we'll get to in a minute. And the third regimen, axitinib and pembrolizumab, also showing similar results, excellent disease control rates. And so if we look at immunotherapy versus anti-angiogenic therapy and compare the side effects, some side effects are more characteristic of one type of treatment versus the other. But certainly, there are side effects that are common to both. And this can be important if you're on a combination treatment that includes an immunotherapy and an anti-angiogenic medication. If you have diarrhea, for example, or liver inflammation, it can be initially unclear which medicine is causing the side effects. And this is why I tell patients it's so important to call your oncologist for any new symptom. Because if we catch it early, we have more time to try to work out which medication is responsible. Perhaps we could stop the pill first, see if it gets better, or depending on how bad the side effect is, immediately start treatment with steroids. To summarize, combinations of immunotherapy and VEGF receptor tyrosine kinase inhibitors, really great initial response rate, very low chance of the tumor not responding at all to treatment. Durability of response, a little bit less clear. Certainly, more patients will need treatment for longer, and there's probably a lower chance of having treatment-free survival. And side effects are common to both types of medications. And so at a very high level, how do I talk to a patient about what I recommend? Some examples are if the patient's really young, the cancer is metastatic, but not too symptomatic, and we have time to take a chance, I'm more likely to try combination immunotherapy, trying to hit that 25% home run where they may be able to get off treatment for many years. If the cancer is more aggressive, causing symptoms that are dangerous, spine symptoms, fractures, for example, I'm more likely to pick a combination therapy that includes a pill for a more rapid tumor response. Nivolumab and cabozantinib and lenvatinib and pembrolizumab both have pretty good data for getting into the brain and bone and treating those hard to reach areas. And axitinib and pembrolizumab have the advantage that the pill, axitinib, only lasts for a half-life of 6 hours. And so for patients who need to stop the pill, axitinib is quite easy to stop. To say this in a different way, if someone comes in and they have favorable risk, meaning no risk factors from the IMDC risk score, the first question I'll ask is, do we really need to treat your cancer? Many of my patients with favorable risk kidney cancer may have very, very tiny tumors that grow by a millimeter or two every year or two. And many of those patients can put off treatment, oftentimes for years with no symptoms, which sometimes is really the right thing to do for quality of life. If the number of metastases is small, there is a role for surgery or radiation or even ablation to control the metastases. Again, hopefully to buy many years of time. For patients who do need treatment, favorable risk, it's a difficult conversation because any of the treatment regimens can be reasonable, and it's a trade-off between how aggressive we want to be and what our goals are. Are the goals long-term remission, or is the goal short-term control? I want to quickly add that sarcomatoid features, which are seen on pathology, tend to be a marker for more aggressive cancers, which respond better to immunotherapy and respond a bit worse to tyrosine kinase inhibitors. And so for patients who do have sarcomatoid RCC, I am more likely to try to give immunotherapy a chance because some of these patients on immunotherapy do quite well, but the ones who don't do well on immunotherapy, unfortunately, have much higher risk. What about patients who do have risk factors? For example, anemia, short development of painful bone metastases. Well, for intermediate or poor risk, if there are sarcomatoid features, I'm really trying to give combination immunotherapy, or at least an immunotherapy containing combination. For oligometastases, if the number of tumors is low, I will still try to do surgery or radiation to all sites of disease. And otherwise, if the patient has time to give combination immunotherapy a try, that is oftentimes a good thing to do. But if the cancer is really problematic, symptomatic, and causing deterioration of quality of life, any of the combinations that include a TKI plus an immunotherapy can be excellent for disease control. In summary, lots of options, very difficult conversations and nuanced conversations in the first-line setting, and no one-size-fits-all approach. Important to remember that this is a bad disease. Truly, it's a bad disease, but more and more, we're seeing some of our patients have really excellent long-term outcomes. Room to do better, and hopefully we'll continue to push the needle. Sometimes patients ask me, gosh, this treatment is making me feel really sick. I wanna take a week off, or I need a lower dose of treatment. Is that okay? Am I gonna hurt my cancer control? And really the answer is no. You're not gonna hurt your cancer control. Breaks are encouraged, dose reductions are encouraged, and actually needed for most patients. And across trials, we've seen that patients who require dose reductions tend to have actually better outcomes, not worse. And this is just likely a result of differences in patient biology. Everyone's metabolism is different. Someone who takes one pill of a medication and has really bad side effects might be getting much higher levels of that medication in their blood. And the way to treat that is by giving a lower dose. I'll briefly touch on what happens if the cancer comes back. Well, we now are fortunate to have options for patients where the cancer doesn't respond well or recurs despite first-line treatment. Some of these options are shown here, with the ones highlighted in green being the ones with the strongest level of recent evidence. I'm going to just touch on the most recent news, just because it's the most recent news, which is the combination treatment of lenvatinib and belzutifan. This was recently presented at ASCO GU this year. This is the first combination treatment with a HIF-2 inhibitor in the refractory post-first-line setting. And patients who received lenvatinib and belzutifan in this randomized trial did better in terms of progression-free survival compared to cabozantinib. And so it's really exciting to see that we have more and more things coming down with novel combinations that will hopefully give us a chance to control tumors even when they have progressed. Are there ways to be smarter about choosing our metastatic treatments? Are there cancer-specific blood tests? The short answer is, for most patients, no. There are the currently available tests, including ctDNA, are relatively low sensitivity for clear cell kidney cancer, but technology is getting better, and many groups, including ours, are actively working on personalized therapies. Just to give one example, the KIM-1 protein is very, very high in patients with metastatic kidney cancer. And when we looked in Checkmate 214, this phase 3 trial, and also in a second phase 3 trial, Cosmic 313, for all patients getting immunotherapy, checking the KIM-1 at 3 weeks gives you a very good idea of whether the patient is going to have a long-term durable remission. And so this data is still actively in development, and hopefully one day will also let us treat patients in a smarter way. And so what if I don't fall into that 70%? What about the 30% which does not have clear cell kidney cancer? Well, there's progress being made there too. I'm not going to have time to get into all the details because there really are a lot of subtypes, but this is certainly a reason to go to an academic medical center, including Fred Hutch or Dana-Farber, MD Anderson, Sloan Kettering, or any other major cancer center with kidney cancer volume. There are some subtypes that respond much better to certain treatments than others. Sometimes clinical trials are available, and we're just now starting to target the individualized biology of some of these tumors. That being said, many, many unanswered questions. We want to be able to personalize our treatment decisions and not treat just based on guidelines. It's not one size fits all. What's the best way to sequence all these new medications that are coming around the corner, including some new exciting ones that are being tested in trials? Which patients need treatment before or after surgery? Can we do things that we've done in melanoma, where giving immunotherapy before surgery is actually even better than giving it after surgery? And how do we develop yet new types of treatment? Hopefully, as we continue to work on these questions, we'll be able to cure kidney cancer patients, cure more patients, and cure patients with less toxicity. And so thank you very much for your attention, and I'd be glad to go through the Q&A.
Vincent, thanks so much. That was just a wonderful overview. So many things that we talk about with our patients in clinic you really touched on. I loved your figure of the change in average survival of patients over time. It's sometimes hard to feel like things are changing month by month or year over year, but if you really look back over tens of years, it's really remarkable how much better things are now than they used to be. One of the questions that was in the chat, there's kind of an ongoing stream, it's maybe you might not have been able to pick it out while you were talking, was a question about nephrectomy after patients have had treatment. What's your perspective on the role for surgical management of the primary tumor if patients have started on initial medical therapy? How does that figure into the overall plan for patients?
Yeah, thanks. So that was a great question. It's actually a question without an easy answer, as unfortunately most questions don't have an easy answer. There certainly is a role for nephrectomy after systemic therapy for some patients. This is a question that is being looked at in clinical trials, but I would summarize by saying that the jury is a little bit still out as to exactly which patients benefit the most from delayed surgery after starting systemic therapy. And so when I talk to patients, sometimes on a case-by-case basis, it really makes a lot of sense. So for example, I have patients on immunotherapy who, after a couple years of treatment, all the metastases have regressed, and all they're left with is a 7-centimeter tumor in the kidney as the only site of disease. In that situation, it makes a lot of sense, in my opinion, to take that last tumor out and render the patient disease-free and hope for a long-term remission. On the other hand, a patient who has painful bone metastases, maybe has recently developed brain metastases, symptomatic other areas of disease. For those patients, taking a break off treatment to do a surgery on the kidney is oftentimes not the best move because you worry about the rest of the cancer growing more during the time that you're taking off to do surgery. And so at this point in 2026, it is an individualized decision. And this is where multidisciplinary tumor boards are so important.
Great, thank you. Something that comes up in practice over and over again that I feel like there's a bit of an absence of data to guide us, and you made reference to it a little bit over the course of your presentation, but people having good success with their medical therapy, is there a time that you come to them and talk about reducing or stopping therapy? Does everyone stop at 2 years? Do some patients go beyond 2 years? And patients on composite regimens, how do you go about deciding to change or stop each drug or both drugs? I'm curious, what what do you talk to patients about as they go forward in time and they're having success about a deadline when they maybe would stop treatment?
Yeah, this is certainly also an area where there's no single one-size-fits-all approach. But what I will generally say for, if I could say an average patient, no patient is average, but if I had to say an average patient, if we're starting combination immunotherapy, I start out by saying that I want to stop at 2 years. If things are going well at 2 years, I want to stop. Not because we have any randomized trials of stopping versus continuing at 2 years. We just don't have that data. But we know that many patients who do stop and are doing well at 2 years never need treatment again. And so to me, it's very important to give patients that opportunity. And in my experience, when we do stop immunotherapy at 2 years, in patients where the cancer eventually comes back, let's say 1 or 2 years later, I have had good success restarting immunotherapy, and oftentimes it still works. And the alternative would be continuing immunotherapy indefinitely with injection every 4 weeks, which can be quite burdensome if we're looking at the whole lifetime of a patient. For combinations with a TKI plus immunotherapy, it really can come down to a case-by-case discussion. If the patient's having a complete response, meaning no measurable tumors, I really hesitate to treat the patient forever because at that point, you don't really know how much benefit you're giving the patient versus the definite harm of giving these medications. And so certainly for complete response, I do stop the immunotherapy at 2 years, and I do pause the TKI. And I tell patients there was a randomized trial, I believe called the STAR trial, showing that if you pause TKI in a randomized fashion for patients with RCC, patients' overall survival is not diminished, and you can restart TKI when and if the cancer grows back. And so to me, that gives data that it's okay to give treatment breaks, even if they're only for quality of life.
Yeah, that sounds great. Um, is it up to your patients? So if you have a conversation at 2 years about possibly stopping therapy and your patient says they're nervous about that, they prefer not to, like, is it permissible? Do they then, or do some of your patients just keep going on therapy?
Yes. And I'm curious to hear if some of your patients do that too. I think it's challenging because it's one of those areas where I don't know the right answer because there was never a randomized treatment discontinuation trial that was big enough to give us the answer. And so generally, my experience is if a patient has been doing great at 2 years, especially if they still have some measurable disease, sometimes the tumor is stable, but there's still a 4 centimeter tumor somewhere, and the patient wishes to continue. I certainly don't categorically say no. I think we think about how much the treatment burden is on the patient and what it would look like to continue versus what it would look like to stop. And I do have patients who continue.
Yeah. I mean, in a sense, it's a good problem to have. And yeah, I agree with you. I wish there was more comparison data to guide us. And I have these conversations and I tell patients we just don't know how to optimize their outcomes. And, a lot of patients are disappointed where they tell me, I'm expecting my doctor to tell me what I should be doing. And you're telling me, I have to decide. But I really do feel like at this moment, it's more of a patient preference. Try and lay out what we know and what we think the options are. But I sense a lot of frustration because there really isn't a clear pathway. Let me just ask you one more question, and if Dr. Gore has anything for you, and we'll turn you loose back to vacation. You mentioned a little bit along the way in your talk about different sites of metastases. I'm just wondering, does that factor into your choices of regimen if you had a newly diagnosed patient with brain mets or you had a patient with liver mets? Does the site of disease for any of the regimens sort of come into play where that would guide you towards what you recommend to the patient?
It does. And some of this is extrapolated. Certainly, there are no, I think it's important to say that there are no head-to-head comparisons between any of the immunotherapy combinations against each other, at least not in large phase 3 trials. And so this is extrapolated from our experience on each of these trials. But I would say that there are some considerations. So, for example, you mentioned liver metastases. If someone has really big liver metastases and their liver function is abnormal, we would try to lean for perhaps a little bit more towards lenvatinib and pembrolizumab because compared to axitinib and cabozantinib, lenvatinib has a little bit smaller chance of injury to the liver. Alternatively, if a patient has brain metastases or bone metastases, I think the data for either brain or bone metastases is a little bit stronger for either cabozantinib or lenvatinib compared to axitinib. And so the sites of metastases do matter. This is not randomized data, but I think that the data that does exist is quite compelling that there are some subtle differences between these medications.
Yeah. Yeah, I know we wish we had a little bit more sophisticated customization, but try and pull in whatever we can. Well, Dr. Xu, thank you so much for joining us this morning. We're really valued having you here with us from Dana-Farber, other side of the country, and giving us a perspective. And reminding the audience this recording will get posted. So if you wanted to watch Dr. Xu's presentation again, you'll have that option. So thank you so much. You're welcome to stay, but if you're not able to, we understand. So we'll move forward here with our program. Thanks again.
Right. Thanks again, Dr. Tykodi. Thanks, Dr. Gore, and great to see everyone. Take care.
Bye now. Excellent. Well, let me introduce our next speaker, a colleague of mine here at the Fred Hutch Cancer Center, Dr. Lisa Tachiki, assistant professor in the Division of Hematology and Oncology, and one of my colleagues that shares care of kidney cancer patients. And one of the groups of patients that is fairly new to our medical oncology practice, syndromic patients with von Hippel-Lindau disease, where we now have a drug to offer them for disease management. So it's becoming a more and more prominent subset of patients in our clinic practice. And we thought this would be a wonderful topic this year to discuss. And so Dr. Tashiki is going to talk to us this morning about Belzutifan for von Hippel-Lindau disease.
Great. Thank you, guys. And I'm just going to talk through sharing my screen out loud so that way I don't mess this up. Okay. And well, thank you so much for that introduction. And good morning, everyone. So as Dr. Tykodi mentioned, I wanted to give some updates on exciting news in the VHL world. A medicine called Belzutifan, which Dr. Xu also touched upon in his talk, is what we're going to be really focusing on during this talk and talking about the newest and longest term study results and how this drug works over time. So my goal is to hopefully not overwhelm you with medical jargon, but give you a picture of where things stand and where we go from here. So what exactly is von Hippel-Lindau disease? It's an inherited condition, meaning it runs in families, and it's caused by a change in a single gene called VHL. So think of that gene like a brake in the pedal for cell growth. When the brake isn't working right, the body can form extra blood vessels and tumors in a handful of places, including the kidneys, the brain and spine, the pancreas, and the eyes. And most people who have VHL find out in their late 20s or 30s, often because one of these growths are found on a scan or exam. Every patient is different, though. Some people deal mainly with kidney tumors, other mainly with brain or eye involvement, but the underlying cause for all of this is the same gene in every organ. So it's important context for understanding why a single medication, Belzutifan, can actually help with all of these different tumor types at once, because it targets the shared root cause and not each organ separately. So I want to take a brief moment here to talk about the biology in plain terms. So VHL, again, is a gene, and when it isn't working, a protein called HIF2 alpha, think of that as a growth signal, builds up inside cells instead of being broken down like it normally would. And that signal tells cells to build extra blood vessels and grow abnormally, which is how these tumors form in the first place. So the reason Belzutifan matters is because it's designed specifically to block HIF2 alpha. So instead of cutting out tumors one at a time with surgery, it turns down that growth signal everywhere in the body at once, including the kidney, the brain, the pancreas, and the eye, because they all share that same underlying switch. And that's fundamentally a different strategy than what had been available before. So Belzutifan, before Belzutifan, really the only strategy for managing VHL was watchful monitoring, followed by surgery once a tumor got big enough to worry about spreading. And that approach worked reasonably well to catch cancer early, but it came at a cost. So in the group of patients in the study that I will be referring to called LIGHTSPARK-004, 97% of these patients had already had one VHL-related surgery before they ever started the study drug. We're talking kidney surgeries, brain operations, pancreatic operations, and sometimes many of these surgeries were happening across a lifetime. So each surgery brings a recovery time risk, and especially for kidney surgery, a gradual toll on organ function. And that's the backdrop against which Belzutifan represents such a meaningful shift. So what is Belzutifan? It's a pill, and it's taken at a dose of, to start, 120 milligrams once a day at home. So you don't have to go into the clinic for an infusion. And it was approved by the FDA in 2021. And because it targets that shared HIF2 alpha switch we talked about, one daily pill can work on the kidney, the brain, the pancreas, and the eye all at the same time. So the data behind the findings we're talking about is from, again, LIGHTSPARK-004, 61 adults with VHL disease, all of whom had at least one kidney tumor, were enrolled throughout the United States and Europe. And everyone in the study took Belzutifan, and doctors tracked how their tumors changed over time. And so the results I'm sharing today reflect an average of about 5 years of follow-up. And this is some of the longest term data we have on this medication. So to start, this is looking at objective response rate, which means the percent of patients whose kidney tumors shrink enough by strict scan criteria to count as a real response. And there are 3 different points of follow-up that we now have. One at about 2 years. Let me see if I can get my laser. One at about 2 years, then at about 4 years, and then most recently at about 5 years. And as you can see, that percentage of people with response increased from 49 to 67 to up to 70%. So this is a really important and striking pattern where response rates went up the longer that people stayed on treatment. So responses were not quick. The typical time to see a response was about 11 months. And some of these tumors kept shrinking for 2 to 3 years. So this is more of a slow and steady medication, not a fast one. And the complete response rate, meaning no measurable tumor left at all, also rose over time from 0 early on to 11% with longer follow-up. And once someone had a response, it tended to last. So over 70% of responders were still responding more than 3.5 years later. So the takeaway is that Belzutifan is a medicine that doesn't just work once and stops. For our VHL patients, these responses tend to deepen the longer that someone stays on treatment, which is reassuring if you're someone who's just potentially starting out on Belzutifan and wondering whether early results you're seeing are the best that we will achieve. For many patients with VHL, these are not, and things tend to keep improving. So taking a zoom out to look at a bigger picture, VHL disease can cause tumors not just in the kidney, but also in other organs, the brain and spine. So for example, a type of tumor called a CNS hemangioblastoma, or in the pancreas, those types of tumors are called pancreatic neuroendocrine tumors, or NETs. And so this slide shows how belzutifan performed across all three. And you'll notice the same pattern in each of those lines. Responses go up over time and not down. And none of these lines are drifting downward or flattening early. They're trending upward and holding steady over time. So if you look at the gold line on the top here, those are pancreatic tumors. These had the highest response rates of all, starting at 77% and then reaching 90, 91%. But at later time points. It's also really interesting to see the complete response rates of these different tumors, with a significant amount, up to 65% of patients with pancreatic neuroendocrine tumors having a complete response. The teal line here represents the CNS hemangioblastomas, which are brain and spine tumors that started off lower at about 30% of people responding, but over time that response reaches about 50%, and about 12% of those individuals had a complete response. So the takeaway here is that one medicine is working across multiple sites of disease at once. In most of these cases, staying on treatment longer was associated with better and deeper responses. This slide is, I think, one that I kind of want to take a moment to highlight this in the next slide. What this is representing, these numbers, are that in the 4 years before starting belzutifan, 75% of patients in the study needed at least one tumor-related surgery or procedure. That's 3 out of 4 people, and some people had needed multiple operations. And then after starting belzutifan, over a similar period of time, about 26% of patients needed any sort of procedure. And most of those happened in patients who had already stopped medication, not while they were actively taking it. So that's a dramatic drop in the day-to-day burden of this disease: fewer operations, fewer hospital stays, and less recovery time, especially for kidneys. That also means better organ function over time. So 59% of patients were still on treatment at the last follow-up that we have, which tells us that this is a medicine that people are able to stick with long-term. And this slide is a little more scientific, but I'm going to walk you through it because once you get it, it really shows a powerful story. So each horizontal line here represents a different patient in the study. And if you look at the middle of the chart here, this is time 0, which is the time that patients started taking belzutifan. So everything to the left here in gray is the time before belzutifan, and it's looking backwards at the 4 years prior to starting medication. Everything on the right here is after taking belzutifan. And you can see here these arrows represent the fact that these are people still on belzutifan. So if you look at these little shapes scattered across each of these lines, what they're each representing, the different colors and shapes, are representing different surgeries that an individual had. And notice, just kind of from a big picture view, how many little spots there are. And if you actually look at the left here, these are the number of surgeries that each individual had gone through in a lifetime. You've got 10, 8, 9, 11. So some of these patients have had significant numbers of surgeries. And then if you shift over to looking at the right side, you see that there are much fewer shapes on this side. And a lot of these bars, we see kind of just a smooth green bar that's uninterrupted. So that's a pretty stark contrast. And for most of these patients, what it means is that after they started belzutifan, the cycle of repeated surgeries stopped, not because their VHL went away, but because the medication kept tumors controlled well enough. So I think the importance of this slide is that it's easy to focus on the degree to which a tumor is shrinking. And that actually might lose sight of what is meaningful. And so this graph really represents, this means fewer pre-ops, fewer recoveries, fewer surgeries to plan your life around. And that's a pretty powerful impact. So naturally, the next question is, well, what does this medicine actually feel like on a day-to-day basis? And overall, I would say belzutifan in our VHL patients has been generally well tolerated. By far, the most common side effect is anemia, which is a drop in your red blood cells and affects about 89% of patients to some degree, though most of those cases are mild. Fatigue affected about 2/3 of patients, and dizziness and nausea affect about a quarter each. Importantly, there were no grade 4 or 5 treatment-related side effects, meaning no life-threatening or fatal side effects were attributed to the drug itself. Serious side effects were uncommon, and they occurred in about 7% of patients, and then about 3% of patients had to stop the medication because of side effects. So while it's not side effect free, their profile here is consistent and manageable, which is reassuring for a medicine that is supposed to be taken for a long time. And I wanted to briefly touch upon anemia because it's the most common thing people experience, so it's worth understanding why it happens. That same biologic pathway that belzutifan blocks to shrink tumors is same pathway that the kidney normally uses to signal to the bone marrow, which is the blood factory, to make red blood cells. So anemia here is what we call an on-target effect, which is a predictable consequence of how this drug works. And there are a few ways to manage it. One would be with medicines that stimulate red blood cell production. And reassuringly, when we do that, there was an analysis that looked at patients in this trial who received these EPO-stimulating medications compared to those who did not, and didn't see any difference in outcome between those two cohorts. Another option would be a blood transfusion, which works quickly, but some doctors might be more cautious if this is someone who otherwise might be considering something like a kidney transplant in the future. And then third would be adjusting the dose of the belzutifan itself, either pausing it temporarily or decreasing the dose. And there's no one single right answer. It's very much a conversation between each individual patient and their care team and their specific situation. And while belzutifan is a promising medicine, like any treatment, there are important personal questions to think about with an individual's care team, not just whether it works, but whether it fits in your life right now. So family planning is a big one. The average age of the individuals on the study that I've been talking about was 41, but VHL disease is diagnosed even sometimes much earlier. So fertility matters. Belzutifan may make some hormonal birth controls less effective. Animal studies raise concerns about male fertility, and we don't have solid human data on pregnancy outcomes with belzutifan. So if an individual is thinking about having children now or in the future, it's essential to have that conversation with someone's doctor before starting on belzutifan. Timing of this treatment also matters because responses tend to deepen over years, and small tumors seem to respond best. So there might be an advantage to starting earlier rather than waiting, but that also means signing up for years of daily medication and ongoing monitoring, which can be a real commitment, especially for someone who might feel well otherwise. And then obviously cost is also a legitimate factor. Long-term daily therapy has its own financial burden, but that needs to also be weighed with the risk of potential surgeries and hospital stays and complications that belzutifan might help to avoid. And none of these have a single right answer, which is why personalized decisions are made best with an individual's care team. And while there's a lot of promising information that I've shared, there's still a lot of questions about what we don't yet know. We need longer follow-up than this 5-year mark to fully understand safety and durability of belzutifan over a lifetime of use. Some of the more rare tumor types, we really just have scattered case reports or kind of what we call examples in the medical literature of a single or just a handful of individuals with how they respond to belzutifan with some of the more rare tumor types like endolymphatic sac tumors or pheochromocytomas. And then researchers are also exploring whether flexible dosing strategies like treatment breaks or adjusted schedules might preserve the benefit while reducing the cumulative burden of daily side effects. And then we also need some better data directly from patients themselves on quality of life and their day-to-day experience. So this is still an evolving story, and ongoing research will help refine how we use this medication. But the takeaways from the belzutifan study in VHL disease are that, one, belzutifan is a pill that can treat the underlying cause of VHL-related tumors at the same time in multiple organ sites. That response rates keep climbing over time. that the need for surgery dropped dramatically after starting Belzutifan, which which really improves quality of life. That side effects like anemia and fatigue are generally manageable, but that this is a long-term commitment and requires a nuanced, individualized discussion with your care team. And then really briefly, I want to take a moment to zoom out even further because as we heard in the last talk, Belzutifan is also being used for kidney cancer in people who do not have VHL at all. So I think it's worth explaining that clearly. Everything we've talked about so far, the 70% response rate and the growing complete responses comes from people with VHL disease specifically. Their kidney tumors behave somewhat differently in that they're usually caught early and are small and have not spread. So the goal of treatment there is to shrink tumors to prevent surgery. Most of the kidney cancer in the general population is different, and it's usually something that we call sporadic, which means it's not inherited. And these patients often are diagnosed later, and their cancer has often already spread. And by the time we're thinking about Belzutifan, they've usually also received other treatments like immunotherapy. So there was a particular study looking at Belzutifan in advanced sporadic renal cell carcinoma or kidney cancer. And in that study, about 2 out of 10 patients responded compared to 7 out of 10 in our VHL patients. So I wouldn't necessarily interpret that as the medicine not working well. It's a very different population with a more advanced stage of disease. So comparing those numbers is not really looking at apples to apples. But the important takeaway here is that it harnesses the same underlying science of blocking that protein pathway that is turned on in kidney cancer. And the discovery, which started right here with VHL patients, is now FDA approved and helping a larger group of people as a treatment in several different circumstances. And the circumstances that I'm referring to are in this column here. So in one regard, we are looking at using Belzutifan for people who are at high risk of their cancer returning after surgery. That has been FDA approved to be used in combination with immunotherapy. One that is currently emerging and Dr. Su also spoke upon is the idea of using Belzutifan with a targeted therapy called lenvatinib after something like immunotherapy stops working. The indication for using Belzutifan after immunotherapy and targeted therapy is also an option. And then down the pipeline, there are also studies looking at Belzutifan in the first-line setting for people with advanced cancer. So the caveat that is that whenever Belzutifan is paired with another medication, it comes meaningfully with more side effects than Belzutifan on its own. And the rate of serious side effects, for example, when we combined it with lenvatinib, nearly doubled in about 52% of patients compared to 30 patients. And most of that comes from things like low blood counts or low oxygen levels, which would need very close monitoring. And I share this because the cost of side effects needs to be weighed cautiously with additional benefit, and it's a real trade-off. So if a combination approach ever comes up for you or a loved one, that's exactly the kind of decision that needs to be made together with a care team, weighing the added benefit against added burden based on what matters most to a patient and their family. So thanks very much for your time, and I'll pause here for questions.
Great, Lisa, thanks so much. Wonderful talk. Again, about an emerging patient population we're seeing more and more in our practice. There were a couple questions for you in the chat. So one of them was asking about the time to response and the perspective that responses emerge over quite a long time in the VHL population. Is that the same for metastatic patients? Is there a difference in the kinetics of when you see responses emerge?
That's a great question. I would say that Belzutifan, when used in the advanced metastatic setting, kind of behaves a little bit differently, I would say, than in our VHL patients, because again, that stage of disease is much different. I would say just from my own personal experience, we tend to see more of a stabilization a lot of times for patients, meaning rather than progressive growth of the cancer, which would happen if we were to do nothing, we see kind of an overall stability. In patients who do respond to Belzutifan, I do still see that it is a little bit slower to respond and can potentially be slowly progressive over time.
Thank you. Another question relates to the metastatic setting. Do you have to know if a metastatic tumor has a VHL mutation to apply belzutifan, or if you know that it does that have any impact on your expectations for the success of the drug?
Yeah, that's a fantastic question. So I would say that interestingly, in our sporadic RCC, VHL is also mutated. The pathogenesis of it, or a kind of why that happens, behaves differently than in these inherited types of VHL. So what we're saying is that the underlying biology that drives the creation of these tumors is similar and harnesses the same concept. So you don't actually have to check for a VHL mutation. And I'm talking specifically, let me be clear, about clear cell renal cell carcinoma. And in that setting, we know that based on the LightSpark data that I was alluding to, that the use of belzutifan there is efficacious for a proportion of patients with clear cell renal cell carcinoma, because those underlying mechanisms still affect the genesis of tumor there as well. So all to say is, in clear cell, because it's an FDA approved medication, I think it's meaningful to think about using. You don't actually necessarily have to check a VHL mutation in order to think about applying it to that sort of circumstance.
Great, thank you. Another question for you was, could there be a role for belzutifan beyond the clear cell patients? And the person asking the question was wondering about papillary renal cell carcinoma. Is there any data, or would it be sensible to test belzutifan in that population?
You know, that's another great question. I would say that I am not aware of any data using belzutifan in papillary renal cell carcinoma. The way and the drivers that we think about leading to papillary renal cell are pretty different than clear cell. So, I generally don't think of belzutifan as having an established role, just because the biologic rationale is different in papillary. So I think that given the kind of scientific understanding of how we think papillary is developed, I wouldn't necessarily see the benefit carry over. But I think it might be meaningful for us to be able to study that, to really evaluate if that's really feasible.
Great, thank you. Sorry, there's one other question that just came in here. How can we avoid overdosage or escape from multi-pharma therapy?
Well, I would say that, I think that's a great question. In an ideal world, we would tailor the dose for every individual. And, we don't have the capacity to do that perfectly, but what I would say is that generally we kind of start with a single dose level at this 120 milligrams, and then we kind of assess overall side effects, including tolerance, including things like how anemic someone gets. And all of those things tell us how the drug is reacting in a specific individual. And then we therefore kind of can titrate accordingly. So I would say avoiding overdosage requires a continued relationship with your provider to make sure that there's an open line of communication in regards to side effects and potentially other issues you might be running into with the medication. I would say that in regards to what I think you might be referring to with multi-pharma therapy, in one regard, when we give a medication, you end up requiring other drugs to kind of help with the side effects of the other. But in VHL disease, that sort of additional medication, that erythropoietin stimulating agent, is actually helping to replace something that this drug repletes. So what it's doing is we're trying to kind of balance out the overall things that we're manipulating here. But I hear what you're saying. When we do take a drug, it is going to cause side effects. And sometimes we then just immediately jump to wanting to give you other drugs to help treat those side effects.
Excellent. Let me ask you one last question, and then we'll say goodbye for this morning. Our VHL patients tend to be much, much younger than our metastatic kidney cancer patients. So seeing new patients in their 20s and 30s that are considering embarking on Belzutifan, and if it's successful, the study that you were referencing has already treated patients for 5 or 6 years. Is this a forever drug that we're going to use for tens of years in these patients? And I'm wondering if you've thought about, do you plan to maybe give patients drug holidays and take time off if it's going really well? What are your thoughts about continuing the medicine, quote unquote, forever versus intentionally pausing to see what happens?
Yeah, absolutely. I think it's tough because we don't have prospective randomized data on this particular outcome. What we're really saying is that we're limited to kind of 5 years of insight that we've had so far from Belzutifan. But I think that trying to balance the benefit of these drugs with real life is incredibly important and requires a nuanced decision. So I would say first, when thinking about especially some of our young patients, I think being upfront about trying to kind of time things around family planning is incredibly important. So if, let's say, someone has many tumors that would benefit from therapy, it might mean having a discussion about some initial upfront use of Belzutifan to hopefully kind of maintain control. And then if we are thinking about family planning or side effects come up, definitely having conversations about taking breaks to help with quality of life and really big life events, knowing that we're kind of in a data-free zone here, but really the ultimate goal is that we can kind of help this. This is more of a marathon than a sprint. This is something where that selective added pressure of Belzutifan over time helps to control what's happening, and providing these breaks are important to kind of try to make this a more sustainable treatment option over many years rather than just months.
Fantastic. Well, Dr. Tachiki, thank you so much for joining us. This is the first time we've had a talk in this program on VHL. So really interesting things to think about. So appreciate your
Thank you,
time.
everyone.
Thank you. Let me introduce our next speaker. Dr. Jina Yoon is a PharmD at our Fred Hutch campus and involved in our kidney cancer program. And I suspect a lot of my patients don't appreciate how much our pharmacy team is involved in their care. Any new cancer drug is reviewed by pharmacy. Any concerns about interactions with other medications they're taking, advice to the provider about any kind of monitoring that's recommended, like checking EKGs. All of the electronic orders that I sign are actually built and created by the pharmacy staff. And there's embedded reminders and flags for the physician about drug interactions. So a lot of things that I'm seeing every day that the pharmacy team is aware of. And we thought it'd be a wonderful topic to invite our pharmacy staff to talk to the audience today about some of the things they think about known drug interactions or suspected interactions and choices that patients might make about things that they're getting access to that are over-the-counter medications. And our patients may be dealing one-on-one with the pharmacy team. They've launched a new patient-facing program to monitor and manage blood pressure for our kidney cancer patients. So actually now joining us and participating directly in patient communication. So for all that they do, really happy to have Jina Yoon join us this morning. And her talk today is to take or not to take drug interactions with immunotherapy.
Great, thank you so much for the introduction. Let me go ahead and share my screen. Okay, so hopefully everyone can see my slides. Please let me know if you cannot. But thank you again for the introduction. So as Dr. Tykodi mentioned, my name is Jina, and I am one of the clinical pharmacists here at Hutch, and I work closely with our kidney cancer team. So for the next about 20 minutes or so, I will be talking about some drug interactions that we are commonly asked about as pharmacists from our patients who are on immunotherapy. So before I really delve into the drug interactions themselves, we do have to talk about what immunotherapy is. So you may hear me call it immunotherapy or also immune checkpoint inhibitors. There's a lot of different ways that we refer to these medicines. Just know that it is kind of a single class of medicines. And immunotherapy really is a cornerstone therapy for our kidney cancer patients, as it's used really in a variety of settings in the treatment of kidney cancer. So it's commonly used after surgery in early stage kidney cancer or in the adjuvant setting. It's also used in combination with oral anti-cancer therapies in the late stage kidney cancers. And as the name suggests, immunotherapy really works by ramping up our immune system. So as you can see on the picture on the right, there are these specific receptors called PD-1 and CTLA-4 that exist on T cells, which are very important cells in our immune system. So without immunotherapy, so on the left side of the picture, the cancer is able to bind to these receptors and essentially stop the T cell activity. The analogy I like to think of is if we are driving a car, the receptors essentially are like brakes. And the tumor really comes in and puts a foot on the brakes in the car, or the T cells from moving forward and having full activity. As you can see on the picture on the right, when patients receive immunotherapy, these agents essentially come in and prevent the cancer cell from putting their foot on the brake, so really taking that foot off, allowing for the CAR or the T cell to really move forward and really work at its optimum. Because the primary way that these agents succeed in treating cancer is by ramping up the immune system, the major drug interactions that we really think about with immunotherapy are going to be any therapies, medicines that really dampen down the immune system and counteract this. And as you can also see at the bottom of the picture, there are several types of immune checkpoint inhibitors. So these can target PD-1, PD-L1, as well as CTLA-4. So in kidney cancer, we typically tend to see pembrolizumab and nivolumab that target PD-1 and ipilimumab that targets CTLA-4. All right, so when we think about drug interactions, there's really several medications that can affect the immune system. The big one that we think about are going to be steroids. So the steroids come in and really dampen down your immune system, especially used at high doses and for long term. And for patients that have side effects in immunotherapy, our first line of treating these side effects are going to be steroids. But for the purposes of our discussion today, I actually wanted to focus on a couple over-the-counter medicines and supplements that we sometimes get asked about from our patients. So really focusing on acetaminophen, proton pump inhibitors, and probiotics. But I do want to say this is in no way a comprehensive list of all the drug interactions that exist with immunotherapy. So I do want to make sure that we're scoping down just for today's discussion. All right, so the first one I really want to delve into is going to be acetaminophen, also called Tylenol. Many patients are very familiar with this medicine as it is used very widely. It's often used for just general mild or moderate pain that patients can take over the counter. If patients have body aches, fevers, it can also be used if patients are having those symptoms as well. There was actually a lot of interest in looking at acetaminophen with immunotherapy and this interaction because we already know that acetaminophen dampens the immune response around vaccines. When patients take acetaminophen regularly before receiving vaccines, we know that their response to their vaccination is really not going to be optimal. And that's why we often ask patients to not take a Tylenol or acetaminophen prior to their vaccination. And because we know that this interaction already kind of exists, we were interested to see if there is this same interaction or same kind of dampening effect with their immunotherapy. In current state, it is not entirely known how acetaminophen dampens the immune system, but it is thought that it affects the T cells that we talked about directly, not only blocking how they work and their full activity, but also their growth. In terms of the data, there's really three main trials that have examined this relationship between acetaminophen and immunotherapy. So the first study that I'll talk about was a smaller trial. So I had 34 patients with advanced solid tumors. So really not just our kidney cancer patients, but a variety of cancers, including breast cancer, melanoma, really any kind of tumors that received either a PD-L1 inhibitor with or without a CTLA-4 inhibitor. So these patients essentially received one or two immunotherapies that took some kind of acetaminophen during their time on immunotherapy. They collected blood from all of these patients, and they saw that in 50% of these patients, they found that patients had what they called a significant acetaminophen blood level. So when they compare these patients with significant acetaminophen blood levels compared to those that did not, they did see that patients with these levels had worse progression-free survival, which is a common outcome that we think about in a lot of our studies, with a difference about 3 months, and also a worse overall survival with a difference in about 9 months. The difference here is shown on this graph, as you can see. So kind of bringing attention to the graph. So the red line is going to be patients that have the significant presence of acetaminophen blood levels, and the blue line are going to be patients that did not. So as you can see, there is a difference, and based on the p-value that's shown on this picture here, the difference here was statistically significant. Based on this result, there was another study that was completed. So really looking at the same population. So again, really a wide variety of patients who are receiving a variety of different immunotherapy agents. But this time they included more patients. So the total patient count for this trial was about 297 patients. And they did very similar studies where they looked at blood levels of acetaminophen in these patients. And they also saw that the results here echoed the results that we see on these graphs. So seeing worse overall as well as progression-free survival in those patients that had that statistically significant acetaminophen blood. So how about our kidney cancer patients specifically? So the last trial looked only at our patients with advanced renal cell carcinoma who were treated only with nivolumab. So really not taking the pembrolizumab or the ipilimumab into account. And this trial also enrolled about 297 patients that were included. And these patients also had what they called a detectable blood level of acetaminophen. And again, similarly, they also saw that they had overall survival. They did not look at progression-free survival in this study, so it's really tough for us to talk about. So what does this mean for us? So before we really talk about the takeaway, there are two really big things I want to talk about and bring to your attention that I think are important for us to think about. So one, I do want to note that the three studies that I talked about were primarily observational as well as retrospective. So meaning that these patients were just included in the study and just gathered, and were just analyzed with no control for any of the factors that may affect progression-free as well as overall survival in our patients that are receiving immunotherapy. So because there are so many factors that can cloud this really, correlation of acetaminophen in immunotherapy, it's actually very challenging for us to draw any really major, strong conclusions from these trials. In addition, it is actually very interesting that all of these studies look specifically at blood levels of acetaminophen. And in real life, we actually never look at blood levels of acetaminophen, nor do we know what really constitutes a detectable or a significant blood level. When we talk about acetaminophen intake, we really talk about the doses that patients can take. We know that the maximum daily dose a patient can take is up to 4 grams. So we think about it in the percentage of the maximum dose you can take. The studies actually even note when they go through their analysis that while they were able to get these blood levels from the patients, that they were unable to fully assess the exact dose of acetaminophen that these patients were taking due to the fact that these are over-the-counter medicines that patients can self-dose. And then they did their best to try to show a correlation of the dose with the blood levels, but they really weren't able to find that correlation. So with all that said, we think that there may be a theoretical interaction with acetaminophen and immunotherapy based on what we think happens with acetaminophen and what we know about the vaccines. But we really need more standardized studies and better information to really help further shed light on this full relationship of immunotherapy and acetaminophen. So currently, we do not ask patients to not take acetaminophen if they specifically have a reason to take it while receiving their immunotherapy, because this relationship of the two medicines is quite unclear. I sometimes do also get asked by my patients, look, if we're seeing this interaction with acetaminophen, do we worry about other over-the-counter pain medications like ibuprofen and naproxen? But we know that these agents work quite differently from acetaminophen. And currently, we don't have enough studies to suggest that there is the same kind of level of interaction. So again, we do not recommend kind of not taking these, especially if patients were required. Great, so next I do want to talk about proton pump inhibitors and probiotics. And I'll kind of talk about these together as a whole. But before we really delve into these medicines, we do have to do a little background on the gut microbiome, because this will be a very important concept for both of these medicines. So what is a microbiome? So microbiome essentially is a colony of trillions of these microbes that live in and on human bodies. The gut microbiome specifically is really important in harvesting these inaccessible nutrients that we get from our diet. And there's a lot of thought that the gut microbiome contributes to our immune system development and function, and that those two are very closely aligned. So how does our gut microbiome help with our immunity? So, the gut microbiome is really important in reinforcing the stomach lining and the mucosal integrity of our stomach. As we eat our foods, there's a lot of potential overgrowth of harmful bacteria that exists in the foods that we're taking in. So these gut microbes can help prevent the overgrowth of these harmful bacteria. And then it's also thought that these gut microbiomes also help with T cell production and function, which again is not only important for our immune system in general, but for how immunotherapy works. So to introduce the two medicines I'll kind of talk about in this setting. So both PPIs and probiotics are thought to affect the gut microbiome, and therefore affecting the immunotherapy through these pathways. So proton pump inhibitors, or PPIs, are most commonly used to help treat stomach acid reflux or help prevent stomach ulcers. In some cases, if patients had any severe stomach issues like stomach bleeding, our providers may prescribe our patients to use them for long term. There are over-the-counter PPIs, and they are most commonly called omeprazole, esomeprazole, and lansoprazole. There are also prescription-only PPIs, including pantoprazole. So these agents essentially work by decreasing the stomach acid production long-term. And this change in the stomach pH, we think, can lead to changes in the bacteria microenvironment, not only in our stomach, but possibly all the way down to the small intestine, and therefore affecting the gut microbiome in that area, and then therefore affecting the immune system well. So probiotics are also over-the-counter supplements that contain different quantities, concentrations, as well as strains of bacteria, really depending on the brand. Not to be confused with prebiotics, which are essentially healthy fibers that are part of our diet. So because these are live bacteria, by taking these, we are introducing a new strain or possibly an overgrowth of a specific strain of bacteria. And this can also lead to altered natural gut microbiome, therefore, again, affecting our immune system, possibly down the line affecting how our immunotherapy agents work. So in terms of the data around these agents, we do have a lot more data regarding the use of PPIs and immunotherapy. And just for the sake of this presentation, I really scoped it down to a couple large observational studies, as well as 2 meta-analyses, which is a compilation of various trials to draw general consensus and conclusion. As you can see, all of these address various cancer types. So this is not only just in our kidney cancer patients, and the ICI types can be also quite variable, so it does not limit to one specific agent. And the endpoints are kind of the big ones that we think about, similar to that acetaminophen trial of, looking at progression-free as well as overall survival. And really the overall purpose of these was to see if there was a difference in this progression-free and overall survival in patients who take versus who do not take PPIs while on immunotherapy. So I do want to focus on the last column of this general findings from these trials. So Overall, as you can see, most of the studies found that when patients took PPIs during their time on immunotherapy, they also have poorer progression-free and sometimes worse overall survival compared to those who did not take any PPIs. And this difference really ranged anywhere from about like 1 to 5 months, as we see here in our meta-analyses and observational studies. The second meta-analysis here specifically also suggests that the duration of PPI usage can really make a difference, showing that long-term usage of PPI is where that impact on that progression-free and overall survival is observed, versus if patients take PPIs temporarily for indication that they need, we may not see that difference in overall progression-free survival. I sometimes have patients ask me if there's one specific PPI that interacts more or less with their immunotherapy. And unfortunately, a lot of these trials don't distinguish between the different PPIs, even between the over-counter and the prescription ones. So they kind of think about them, all of them as a whole. And we do think that interactions should be equally present in all of the agents. I don't have these on the slides, but there have been some studies that have looked into similar interactions with probiotics. But really interpreting these studies is definitely a lot more challenging. First, probiotics are supplements, meaning that the FDA does not regularly meaning that what is on the label may not actually match what's in the product and what the patients are taking. There was a specific study that looked at patients receiving immunotherapy for the treatment of melanoma, and they found that in these patients who took probiotics, they actually had worse outcomes. While we've also had other trials suggest that taking probiotics fortified the gut microbiome and possibly lead to better outcomes while on immunotherapies. There are other also studies that looked into specific concentrations of bacteria that are optimal to take while on immunotherapy, while others suggest that there's maybe a specific strain of bacteria that's more important to think about when patients are getting immunotherapy. So all to say, really, we don't have a lot of concrete data around probiotics, and this is definitely an evolving area. And we don't have enough robust data to really make strong conclusions at this time. So a couple takeaways from this section. So for PPIs, we do have a good amount of data to suggest that, long-term, especially, use of PPIs may affect the immunotherapy. So for our patients who don't have a specific reason to be on PPIs, we do our best to recommend discontinuing them when able. We sometimes have patients who have been taking them for acid reflux that's over the counter. For those patients, we may work with our patients to switch to another product that may not have this interaction, such as an antacid or famotidine, which can both be, again, found over the counter, which may still help with their acid reflux. But we do also understand that we may have some patients who may require these PPI usage long-term for stomach issues. And for those patients, the benefit of taking them may outweigh the risk. As I mentioned, for probiotics, we really don't have enough evidence to recommend the usage with concurrent immunotherapy. So similar to PPIs, we likely will discourage usage if able. We sometimes get asked if patients can have foods that have high probiotic content, so including yogurts and fermented foods. So I do want to say these probiotic supplements tend to have much higher concentrations of probiotics than what we get through our foods. So while we may discourage taking probiotic supplements, we typically will encourage our patients to continue eating the foods that they enjoy and maintain their nutritional intake as much as possible. All right, so to end this presentation, as I mentioned, we really only talked about a snippet of drug interactions with immunotherapy. And even with a couple that we talked about, this is definitely a very big growing area. There are other over-the-counter medicines like antihistamines or allergy medicines, as well as prescription medicines such as statins, which are commonly used to help lower cholesterol, and SSRIs, which are commonly used to help with mood, that are also being studied. And the drug interactions I really focus on today really talked about counteracting the effects of immunotherapy, so really going against it. But there's also a lot of growing interest in finding possibly medicines that potentiate the effects of immunotherapy in our immune system. All this to say, talk to your team if you have questions or concerns about your medicine. As you can see, as we kind of talked about the drug interactions here, it's really not black and white. And there may be times where it is more beneficial to take these medicines than to avoid it. And as Dr. Tachiki mentioned in his previous talks, there's a lot of additional context that we take into account to help make a personalized plan. So that could include, the patient's response to immunotherapy, other side effects they're experiencing, their past medical history. And so it's really important for us to have that conversation as a whole. Lastly, I do want to put on a plug that we do have an innovative medicine team here at Fred Hutch. They're a very wonderful resource for patients who want to maybe further discuss supplements or kind of other holistic approaches to their care. And they're a really great resource for our patients. All right, I think that's it. Thank you so much, everyone.
Great, Jina. Thank you so much. That was a wonderful discussion. Just one question I had, going back to the beginning of your talk. We often do recommend acetaminophen for patients. In our world of kidney cancer, a lot of our patients have had a nephrectomy, and their surgeon has warned them off about don't use ibuprofen or naproxen class of drugs. And so the other agent that's over the counter is acetaminophen. So to hear that there's a possible concern with acetaminophen, kind of puts them in a difficult situation. But has it been looked at for the NSAIDs and association in the same way with acetaminophen? And then what about prescription pain medications, narcotics, if a patient was prescribed oxycodone or Vicodin in lieu of Tylenol, or, well, I guess not Vicodin, has Tylenol, but oxycodone. Are there similar concerns for other drug classes that would be alternate pain medications?
Yeah, that's a really great question, Dr. Tykodi. So for our NSAIDs, we really don't have a lot of data. I don't think there's as much interest because that kind of foundational knowledge about that interaction with the vaccines is really with the Tylenol compared to like the NSAIDs that we see. I know there is growing interest and there is some preliminary information that's coming out, but nothing that's really established so far. I mean, I do agree with you. It can be really scary to hear that there's this interaction for our kidney cancer patients because we do ask them to avoid the NSAIDs. But the big thing I really want to focus on is we really don't know enough quite yet. And for a lot of our kidney cancer patients, it would probably be the benefit of taking acetaminophen probably outweighs that risk until we have more information.
Yeah. On the same theme, somebody just put a question, what about aspirin? I mean, that's different than acetaminophen. Again, is there an absence of data, or has that been looked at in the same way?
I think that's also an absence of data. So the NSAIDs kind of combine all of them, the aspirin, the ibuprofen, as well as the
Yeah, thank you. Somebody asked a question, which is a great question, but I think probably beyond the scope of what we have time for today, which was using mRNA vaccines plus immune checkpoint drugs, which falls under the umbrella of a drug-drug interaction, and it's an interesting topic, but I don't think we probably have time to tackle that. While I have you here, can I just ask you before you go, one thing that gets called out very frequently with cancer medications of all kinds is to avoid taking them with grapefruit juice, which seems like a very odd thing to come up. What is the issue with grapefruit juice? Why are people counseled to avoid that with a lot of medications?
Yeah, great question. So the grapefruit juice has a specific enzyme that prevents breakdown of a lot of the medicines that we use. So the concern that we get is patients are eating grapefruit with a lot of the therapies that we're recommending, that there is possibly an increase of the therapies, possibly leading to more side effects. And so, side effect is one big thing that we, talk about and think about for our patients. So we do our best to avoid this interaction if possible. With that said, when they specifically looked at grapefruit intake, I think patients need to have maybe like 20 grapefruits a day, every single day, for this interaction to be very, very strong. So, patients want to have a grapefruit here and there once in a while, that is likely going to be okay. But we tend to avoid as much as possible to minimize that risk of increased side effects.
Excellent. Well, Jina, thanks so much for joining us this morning. Really appreciate your talk and your time. So thank you. We will move forward to our next speaker and the last speaker before we take a short break. So I'm delighted to welcome Bryan Lewis. Bryan has been here in past years. Bryan's the CEO for the KidneyCAN patient advocacy group. And so a wonderful voice in the kidney cancer world and kidney cancer space, and very dear to my heart, strong advocates for funding for kidney cancer research. So let me hand it over to Bryan to tell you a little bit about KidneyCAN and their mission. Bryan?
Great. Thank you, Dr. Tykodi. And thanks for this opportunity as well, Dr. Gore. Thank you for having me. My name is Bryan Lewis. I'm the CEO of KidneyCAN, and we're located in Philadelphia and Washington. And I apologize in advance. I'm not the best at slides, so I'm getting some help today. KidneyCAN was created by patients, and everything we do is focused on trying to accelerate cures for kidney cancer. And today I want to share who we are, how we support patients, and how we help move research forward, and why advocacy remains such an important part of that work. Before I begin, I want to acknowledge KidneyCAN's partnerships and support. We receive support from a number of organizations across the kidney cancer space, as well as from patients, caregivers, families, and friends. I'm also involved in several advocacy and advisory roles that reflect my commitment to keeping the patient voice present in research and policy conversations. Excuse me, next slide. As CEO, I wear that hat, of course, but I'm also a patient advocate at the core, and that perspective shapes how I approach this work. KidneyCAN exists because patients and families saw a need for greater urgency, stronger collaboration, and more investment in kidney cancer research. And my kidney cancer journey began in 2007 when I received a diagnosis of metastatic disease, T3N1, M1, if I remember correctly. I was fortunate to be picked up by the NIH after a radical nephrectomy, and today, 19 years later, I'm living with no evidence of disease. I do know how fortunate I am, but I also know that not everyone gets this outcome. Too many families are still losing loved ones to kidney cancer. Next slide, please. So we created KidneyCAN to bring together researchers, clinicians, patients, advocates, and the industry. And we wanted to provide those resources to build this community with a shared purpose to accelerate cures. We were formed in 2016, and we were frustrated by the slow pace of discovery in kidney cancer. Now, this is a community of people with literal skin in the game who refuse to accept the status quo. And it's that founding spirit that continues to drive us today. We're not a big institution. We take pride in being a constructive disruptor. We're respectful, collaborative, and intensely focused on removing barriers to research. Next slide, please. So in accelerating cures, we do this, I'm sorry, the previous slide, my mistake. We do this by 5 pillars we look at. First of all, is awareness building of kidney cancer. We try to build on those 2 words. We try to then recruit advocates to help us in moving forward after gaining that awareness. We believe that advocacy leads to funding, and we've been fortunate in that front. We'll talk about it in a moment. And that funding leads to more research, and ultimately research is going to lead us to cures. And so we work to create hope and improve the lives of everyone. However, supporting patients is at a cornerstone of that mission, and we do this in 3 primary ways. And in the next slide, please. We have a patient resource center. We hold interactive town hall webinars throughout the year, and we participate with Smart Patients, a forum where patients can connect and share their experiences. Next slide, please. Our Patient Resource Center is a curated hub of knowledge designed to meet patients where they are in their journey. Whether you're newly diagnosed, you're managing treatment, or you're living long-term with kidney cancer, there are resources like articles and videos, and we decided not to go out and recreate the wheel. There are a lot of good resources out there. You'll hear a number from Amy coming up after me. They've got a lot of good resources, so we just wanted to collate and curate the best that's out there. And we also help patients in finding the right care team and the right doctors to understand their treatment options. Next up, our town halls are these dynamic, interactive events we hold throughout the year to connect patients with some of the leading experts. And these webinars cover crucial topics like treatment advancements or managing side effects and navigating clinical trials. And I think most importantly, attendees can ask their questions live, and they make these sessions a direct link to some of that expert advice. And now the next slide. But sometimes, the best resource is someone who's already been through what you're facing. And so through our Smart Patients Forum and partnership, KidneyCAN works with holding not only community socials, but also directing folks to this resource where they can connect with others who truly understand the kidney cancer experience. And you'll hear from smart patients later today. That kind of connection, we believe, really matters. It helps reduce isolation, it builds confidence, and it allows people to feel like there's a community here for them. And we want people to see KidneyCAN as more than just a program or one event. We would like you to be able to find a community with education and advocacy opportunities and the ways to stay engaged with our broader kidney cancer ecosystem. And some people come to us looking for support, and others come looking for a way to make a difference, and some come for both. And so I encourage you to follow us on social media. It's an easy way to stay updated on patient resources, advocacy opportunities, et cetera, and the stories of hope within that community. Next slide, please. So what does it mean when we say accelerating cures? What do we really mean by that? And what we mean is it's shortening the path between discovery and patient benefit. And it means helping to move good ideas forward faster, supporting collaboration, advocating for research funding, and making sure that the patient voice are helping to shape the priorities that guide our work. And accelerating cures is not just one thing, it's the result of these many things working together. Next up, please. So for starters, let's consider, how does life-saving research really happen? What does it take to develop a cure? Well, I think you all know it takes people not working in isolation. It takes caregivers and patients and clinicians and researchers and industry and policymakers and funders. And everyone has a role. And our role is to try to help connect those pieces, to bring those people together, to advocate for the resources this work needs, and to keep the focus on outcomes that matter to patients. Next slide, please. So even with the progress that we've seen, kidney cancer research has historically been underfunded. If you could have, on the previous slide, you would have seen that there's just a number of grants that are being given out by the American Cancer Society every year. And unfortunately, even though we're number 7, 8, or 9 in the top 10 of cancer diagnosis every year in the US, it's sort of an abysmal number of research projects that were being given out compared to some of the others. We just use this as an example of we have a lot of catch up to do. Next slide, please. So although we've been underfunded, there's a lot of promising ideas out there. And we feel like one of the biggest ways to change that is to advocate in Washington, D.C. to try to get those research funds that are available. And so you can see some of the different pictures of us up on the Hill. When patients and caregivers and researchers speak as one voice, it can change what is possible. And advocacy has raised the visibility of kidney cancer in Washington. We've built a lot of relationships, and we secure meaningful federal investment in research. And I think this community has made a difference. Advocacy is something that you can participate in, and it's something not to shy away from because you've not done it before. We provide a lot of training and a lot of hand-holding along the way, and it's not hard, and a lot of people can get up and running the very first time, and it's an enjoyable, plus I think a rewarding experience. Sharing your insights with lawmakers transforms the conversations and can help us all secure that vital funding that we need. Next slide, please. But then came 2025 after we had secured a lot of funding for kidney cancer, funding through the Department of Defense. That funding came to a screeching halt. There was a 57% cut in the congressionally directed funding, and there was a 40% cut over at the NIH, the National Institutes of Health. And so you can see that with these, it was a serious setback for all of us, but we weren't going to quit. It was a reminder that we had some gains that have been lost, but advocacy is not only about what we're doing, but it's about pushing forward. And so we're out there trying to protect that progress that this community has fought so hard to make. Next slide, please. And so you can see here that cliff that took place in 24, 25 went back $0 were allocated in fiscal year 25. But through our efforts and others, we've been able to reinstate 15 or 15 million dollars back into the program, and that money never comes to KidneyCAN or any of our patient organizations. It's managed through the Department of Defense and the Department of Army, and those grants are all given out through those organizations. Next slide, please. We just did hear that the House of Representatives has passed the $15 million in their defense bill for kidney cancer. So at least on the House side, that $15 million number is there. We're waiting to hear from the Senate. This probably this week coming up. We can hear a number, and hopefully we're going to continue to have at least 15 million going forward for the research community. But we've got a long ways to go to restore ourselves back to the prior 50 million annual appropriation we had. If you're interested, there's a QR code here you can hopefully scan if it's up there for a moment. You can reach out to kidneycan.org. We're going to be having our fall advocacy days. We send a small group of people into Washington, very targeted appointments with appropriations people and staff. And then on September 22nd, it's open to the country. And we have people from across the country. We had almost 47 states last time. And we've had over 2,500 meetings with our representatives, and we could use your help. No experience is necessary. We'll provide the training and support for that. So I think just the next slide, and this is just an example of, or those. Hopefully, you can take that QR code. And we'll just move on to the next slide. So on that note, I'm going to wrap it up. I know you all have a break coming up. You're going to hear some more good information from my colleagues coming up. And Dr. Tykodi and Dr. Gore, just really appreciate the opportunity to share what we're doing, and encourage anybody to join us at our website or on social media if you're interested in talking some more.
Bryan, thank you so much. We love having you participate and putting information out there that our patients might follow up on. Just, Bryan, one question. You'd shown some of the information from KidneyCAN, including webinars. How would people listening be able to find out about the webinars? Do they go to the website and sign up for that?
Yes, please. We have a sign up form that pops up on the website once you land there after about 10 seconds. So if you go to kidneycan.org, there'll be a registration. It'll allow us to send a newsletter as well as announcements of upcoming webinars. Fantastic.
Well, again, Bryan, thanks so much. That brings us to the conclusion of the first half of our program today. We're doing pretty well. We're just a couple minutes behind the schedule. Let's take a 9-minute break and come back at 11:10. We'll sign back on, and Dr. Gore will lead us into the second half of our program. Thanks, everybody.
Welcome back, everyone. The first half was a really wonderful overview of a lot of different things that shows how many exciting things are going on in kidney cancer. One thing that we are lucky to have in kidney cancer is some really wonderful organizations that support our patients, that support research. And so we have a couple talks from our advocacy partners. And so I would first like to introduce Amy Marbaugh from the Kidney Cancer Association, who is going to describe some of the activities and support systems of the KCA. Thank you, Amy.
Well, great. Good morning. Thank you, everyone. All right, let's make sure I can share my slides correctly. Can everyone see that?
Yes.
Awesome. Wonderful. All right. Well, welcome back, everyone. As Dr. Gore said, my name is Amy Marbaugh. I am the Senior Director of Patient Programs at the Kidney Cancer Association. And I just want to first thank Dr. Tykodi, Dr. Gore, the Fred Hutch team for inviting the KCA to speak to you all today about the resources and support that we provide to the entire kidney cancer community. The KCA was founded in 1990 by a small group of patients and doctors and has grown into a large international organization. Our 4-pillar mission focuses on education, research, advocacy, and in support and empowerment for the patient and caregiver community. Understanding your kidney cancer diagnosis and treatment options is very important. The KCA debuted new patient education last year, launching all new updated content on our website. You'll find a section for those newly diagnosed, a robust section on understanding kidney cancer, including how it's diagnosed, treated, and cancer survivorship, and life after nephrectomy, which includes physical changes, mental and emotional health, and diet and nutrition information. We also have a section for caregivers on the website, and we also have printed materials that you can download and request printed copies of in addition to our online education. Each year, we host several educational events, including our virtual patient symposium. This year, VPS is scheduled for Saturday, September 26th from 8 a.m. to 1 p.m. Pacific time. You can see the topics covered this year on the right-hand side of the screen, and our topics are generated based on patient and caregiver feedback and questions. We really try to tailor the information shared to what we're hearing from the kidney cancer community. Anyone affected by kidney cancer is welcome to register and attend the virtual event. All of our events are always free. Additionally, we have several digital tools on our website, including a clinical trial finder, which you can use by searching for your kidney cancer type and stage to see a list of trials that you may want to discuss with your doctor. We also work with Savor Health, who created an app called Ina, or the Intelligent Nutrition Assistant. You can use the Ina app to find nutrition and recipe tips, as well as how to manage some of those GI symptoms you may be experiencing due to your treatment. We also have a video library of experts answering commonly asked questions regarding kidney cancer, such as understanding the different types of kidney cancer, treatment options, mental and emotional health, side effects, and much, much more. We're really proud to offer 2 virtual support groups that meet once each month. Our Patient Perspectives group is open to all patients and all patients, and our Caregiver Connections group is open to caregivers, friends, and family members. We're also have a patient liaison on staff who answers calls and online messages from patients and caregivers. She can help answer questions about finding supportive resources, financial assistance, and so much more. And we also launched a podcast a few years ago called Kidney Cancer Unfiltered. It's a patient-led podcast, and we're getting ready to launch season 6 of the podcast this fall. And you can find it anywhere you listen to your other podcasts. Some other things that we offer: caregiver and patient care packs. The items in each care pack was recommended by patient and caregivers as items that they thought would provide comfort and help to their cancer peers while managing their diagnosis. We also offer peer mentoring through Immerman Angels that matches support seekers with experienced mentors to provide one-on-one support. And we also promote a couple online support communities. One is KCA's own Facebook community, which is open to anyone affected by kidney cancer. And the other is Smart Patients, which you'll hear about more just in a few moments. We offer so many different activities and events throughout the year. We're hosting a virtual meetup with our partner organization, Man Up to Cancer, later this month. And we offer different virtual events throughout the year. We could always find details about all of our events on our KCA patient event calendar, which is located on our website. As you may know, Kidney Cancer Awareness Month is in March, and of course the KCA raises significant awareness about kidney cancer during this month. We also sponsor a fundraising challenge each year. This year's challenge was the 81K challenge, as approximately 81,000 individuals are estimated to receive a new kidney cancer diagnosis in 2026. Now, I know I went over a lot of different services, so if you didn't get a chance to scan those QR codes, I will drop all of the links in the chat so you can learn more about all of the resources and events, activities that we offer. You can always find more information at the KCA website, kidneycancer.org. You can follow us on most social media platforms: Facebook, Instagram, LinkedIn, Twitter, X. And again, a very special thank you to Dr. Gore, Dr. Tykodi, and the Fred Hutch team for allowing us to speak today.
Thank you so much, Amy. That was wonderful. No TikTok?
No, we have TikTok. It's not used a lot. TikTok's it's a little hard to get into the TikTok world.
Thank you so much. Thank you. Also on a Saturday morning. We really appreciate it.
Of course.
Our next speaker is Kristi Lynden, who joins us from Smart Patients, and she's going to talk about how Smart Patients can connect patients and caregivers, both locally and nationally and beyond. Thank you, Kristi.
Helps if I unmute myself. Good morning, everyone. Thank you so much to the Fred Hutch team for hosting us and giving us this chance to talk a little bit about what we do at Smart Patients, and also to my unexpected hype people, Amy and Bryan, for kind of giving us a little bit of a shout out. We are excited to share a little bit about Smart Patients. As I said, our organization was founded in 2013 and became the new home of ACOR's cancer communities. Our kidney cancer community was one of our strongest foundational communities and continues to grow and strengthen over time. For those who are unfamiliar, Smart Patients is a peer-to-peer support platform for patients, caregivers, and family members navigating serious illness. Everyone who joins Smart Patients joins at no cost and is only required to provide an email address, username, and password to sign up. The members are our backbone and the driving force behind the work that we do and the collaborations that we form. While our goals and objectives have grown and evolved over the last 13 years, our mission has remained the same: to empower patients with knowledge and connection. We often get asked how we're different from other platforms. First and foremost, we take privacy very seriously, and trust is paramount with our members. We recognize the challenges that come with acute illness and that people don't have time for nonsense. For that reason, we do not promote or advertise within the platform. We maintain this as a space for patients, caregivers, and family members to connect with others who know what it's like to walk in their shoes. We host educational events where we invite clinicians to the community for guest appearances and announce that they will be joining us for a set period of time. We take extra steps to ensure that people are following our standards of community engagement. Those standards are respect and care, safety and privacy, and support and belonging. People join Smart Patients for a variety of reasons. They might be seeking social and emotional support, whether they're newly diagnosed or facing ongoing difficulties, uncertainty, and adversity. They may be offered a new treatment or medication and would like to seek the wisdom of others with relevant experience. Whatever the reason, our hope is that the conversations at Smart Patients give them greater knowledge, confidence, and support to become their own best advocates and face the challenges ahead. Members are encouraged to participate and share at their own comfort level. Time and time again, we see people become experts in their own condition and grow from timid newcomers to welcoming ambassadors and seasoned vets. The conversations at Smart Patients cover a wide range of topics and sentiments. Some tackle very complex clinical details, while others focus on the roller coaster of emotions experienced. While you may have the same diagnosis as other members, everyone's journey is different. Having a place to ask questions and find common ground can improve the overall experience. Some of the benefits of joining this private, safe, and moderated space are anonymity and pace. Members can fill out a profile if they want to share details, or they can just be identified by their username. They can log in and participate at a pace that works for them. There's 24/7 support, so members can ask questions and simply listen whenever they need it. There's support from understanding individuals. Members connect with people who genuinely understand their experiences. There's a reassurance of not being alone. You're part of a community, and there's confidence to ask questions and share experiences. Over time, we see members feel empowered to ask more questions of providers and share their experiences and goals rather than being passive participants in their care. As I stated earlier, we are very appreciative of the opportunity to get to speak to people at events like this, and we take our partnerships very seriously because we recognize that in supporting a lot of different disease states, we can't cover all of the ground of what's new. So when we link with organizations such as Fred Hutch, KidneyCAN, and Kidney Cancer Association, we're then able to provide patients with a myriad of support options for their kidney cancer diagnoses. We form these partnerships to connect more people with vetted resources that provide the latest science, treatments, research, advocacy, and policy initiatives, as well as connection to highly regarded clinicians. In turn, we provide a safe space for people to connect and share their lived experiences. New members enter a conversation feed where they can browse relevant conversations already in progress or dive right in and ask questions of people in similar situations. While they may have initially entered through the kidney cancer community, once they're an established community member, they would have the added benefit of joining any of our 120 plus communities relevant to other health concerns they or their loved ones have. Additionally, we have a large and booming caregiver community because oftentimes caregivers are overlooked. And so it's super important that they have that health or that support of other people who are also navigating the challenges of being caregivers. The power of peer support has demonstrated you don't have to navigate this alone. You can learn from others who have been there. You can get practical advice on treatments, side effects, and day-to-day living. You can feel understood in a judgment-free zone. It's worth mentioning again, there's no cost to join, there's no advertising and no promotion, and you will be in the company of peers and their families who know firsthand the challenges that accompany diagnosis. We'd love to welcome more members into this incredible and supportive community that will help you every step of the way as you face kidney cancer head on. I'd love to open it up to any questions.
We do have time for a couple questions if anyone has any questions for Kristi. And we've put a number of links in the chat. So Amy put a number of links from the KCA in the chat, and we have a number of links to the Fred Hutch Smart Patients page. So you can just find that in the chat on the side.
I'll also mention that we work with Immerman Angels as well because we recognize that sometimes you want a different type of support. So we try to meet people where they're at. So whether you're wanting to come to a group community and get the wisdom of crowds, or you just need that one-on-one attention, we have kind of a two-way relationship with them as well so that we can give people multiple options for support.
Yeah, cancer can be a very isolating diagnosis. So thank you for everything that you do. There is, oh, sorry, I don't think that's a question for you, Kristi.
No problem.
All right, well, thank you so much for your time. Thank you for joining us, and thank you for everything that you and your organization do. We really appreciate it.
Well, thank you. I appreciate you and giving us this opportunity. And as I said, our kidney cancer community was one of the first and still remains one of the strongest on the platform. So we appreciate everybody who comes to us and is willing to entrust us with being the community that they can share this information. Perfect. Thank you.
One of the things we talked about earlier today is the importance of feedback and the importance of filling out the review that you'll see at the end. And we do take these and revise the program every year. And last year, which is very common many years, there was a pretty striking request for more information on nutrition. And I know that this is a question I get a lot in my own practice. Are there things that I can do with my diet that's going to help me with my kidney cancer, whether it's for localized disease or patients with more advanced disease? And so we're lucky to have Kerry McMillen join us today to talk about nutrition, facts, and fictions.
Thank you for the great introduction, Dr. Gore. I'm very excited to be here, and I'm going to just share my screen with you all. Get it into presenter mode. And as Dr. Gore said, there are many, many questions about nutrition that come up throughout the continuum of care in oncology. And my hope today is just to go through in about 20 minutes some key highlights of what comes up frequently in clinic for me. So I am the Director of Oncology Supportive Care and Screening. I am a registered dietitian, and I've been lucky to be at Fred Hutch for by now almost 30 years, which seems hard to believe. I have some disclosures, really, which are none. I'm an employee of Fred Hutch. This is not something that is a substitute for medical nutrition therapy or medical advice. So we would always just recommend for individualized recommendations, make sure you're talking with your medical team. And certainly that includes requesting a consultation with a registered dietitian. So what we're going to cover today are, as Dr. Gore mentioned, just nutrition strategies. I know there might be a mix here of people who are in active treatment and also in survivorship. I'm going to go through some common questions that we get, and then especially to address supplements. This is one of the biggest areas that people get confused about. Do you need to supplement? Are they recommended? Can this help prevent or cure cancer? So we're going to walk into a few of those questions. And then I really want to leave you with some very recommended resources that are well vetted and certainly can give a lot of information. So let's dive in. The first thing I want to say is that there is a difference if you're looking for nutrition advice outside of your medical center between a nutritionist versus a registered dietitian nutritionist. So basically, all dietitians are nutritionists, but not all nutritionists are dietitians. And so when you're looking for really vetted nutrition advice, we would recommend that you see a registered dietitian just because there's much more rigorous training and internship and requirements to maintain our credential. And then specifically for oncology, what you would want to look for is someone who has the designation of a CSO, and that's a board certified specialist in oncology nutrition. Most of our major cancer centers, including Fred Hutch, our nutrition team is comprised of registered dietitians that are CSOs, but I just wanted to give you that little bit of information as this talk only covers so much and you might have additional questions that you might want follow-up in. So let's really dive into the whole, I was going to say the meat of the situation, which is appropriate because we are going to talk about protein. So talking about nutrition strategies, really one of the main things we like to emphasize for anyone going through any active treatment or in survivorship is there's a lot of talk about weight. And sometimes people feel like weight loss can be the silver lining of treatment. But we really know that if people are not eating well, your losing weight can often mean that you're losing muscle. And this is exactly the kind of weight we do not want you to lose. So our goal is to really to maintain your weight through treatment to prevent loss of lean body mass. So that's just a really key point. The other thing, as I know people have mentioned, is that it's very important to have adequate fluid intake to maintain your kidney, and it's very important for bowel function as well. And then across the continuum, you hear a lot about making sure you're eating the rainbow or getting in fruits and vegetables, things like that. Depending on how you're doing in terms of symptoms, it might be important to modify how you get this type of nutrition in your diet. So I just wanted to say, sometimes if you're in active treatment and you might be struggling with side effects like nausea, or perhaps you're having lack of appetite, or you're having diarrhea, sometimes it's easier to tolerate your fruits and vegetables in soups and smoothies if you're not feeling as well. And we'll come back to this topic, but what's really important, and especially emerging in the lane of immunotherapy, is that the gut microbiome is very important. We often don't think about our gut or GI tract, so stomach, intestines, etc., as an immune organ, but it's actually our largest immune organ. So we definitely want to make an effort to ensure that we're feeding it well. Also, just to mention, you certainly can meet your protein needs if you are vegetarian or vegan, but there are studies that show that animal protein might be easier to digest than plant protein, especially when you're going through any type of active chemotherapy and having adverse GI symptoms. So really, the message here is let your medical team know if you are struggling with eating, going through treatment. They can refer you to a registered dietitian, and we would be happy to meet with you to talk about any cultural food preferences, individual circumstances, or any diet preferences that you might have. So as I mentioned, protein is essential. And I think this is one of the areas where Google or other sources of information that maybe isn't geared toward oncology starts to paint a picture that you have to go keto, you really need massive amounts of protein. But actually, that's not the entire story. Yes, we know protein is important and it's essential for many functions. I mentioned muscle. So if you're eating enough protein, but you're not active, it's really hard to gain muscle. And if you're active, but you're not eating enough, or if you're eating enough protein, but you're not active, it's also hard to maintain your lean body mass. So both are important. But it's not just the protein that's important. It's very important to get adequate calories too. If you're constantly at a calorie deficit, your body will actually use your muscles to create energy, and that's not what you want. So again, protein can also support structural integrity, so healthy skin, hair. It supports wound healing, and it also can support adequate blood count. So it's a really essential nutrient. So to think about, well, how much protein do I actually need? Not everyone needs to get out their calculator for this, but just as an exercise, I thought I would go through just some averages. So generally speaking, it's about 8.8 grams of protein for every kilo of body weight. Not all of us in the US translate pounds to kilograms regularly, so I put a few different weight classes down. So the range is 50 to 70 grams per day if your weight is somewhere around the 140 to 200 pounds. And so the way that you can start to figure this out is then you can start to think about looking at food labels. I can give you just a brief cheat sheet example where if you envision a deck of cards, that's about 3 ounces. So 3 ounces of any meat, fish, etc., would be about 24 grams of protein. So really, if you start to break that down, you don't need to think about eating massive quantities of protein. There might be times where your protein needs are a little more than that if you have a lot of wound healing. Say, for example, you just got out of surgery, which can be common with this diagnosis. You might need to bump that up, and your team would give you information about that. But that's just really important because I feel like I get that question a lot from patients. They feel like they just have to pound all this protein, and when when they don't have a great appetite, it's very hard to accomplish. So again, as I mentioned, there's a lot of protein sources out there. You can have protein sources from plants. So think about your beans and lentils, including soy foods. If you're someone who loves tofu or tempeh, these are great plant-based protein sources, including things like nuts and seeds in your diet, high protein grains like a quinoa, and then also there's higher protein vegetables. Animal proteins, so think about, dairy, eggs, poultry. I do have red meat in moderation because when we start to think about cancer survivorship, the recommendation is per week eating less than 18 ounces of red meat and to limit or avoid the processed meats. And those, we all love a good piece of bacon or maybe some salami on a charcuterie board, and that is okay. But generally speaking, what they say is okay is in moderation. We know that the processing can actually put us at risk for other cancers. So those are in the limit avoid category. You also can get supplemental protein, and that can come from protein powders, protein shakes, liquid nutrition supplements. Those can be best, though, utilized when we can't get enough protein from whole foods. And the reason for this, as I will allude to in a second, is really the importance of supporting the gut microbiome. So we often get questions, can I get enough protein from a plant-based diet? And the answer is absolutely yes. It once was thought that plant forms of protein had to be eaten in these magical combinations, like you couldn't get all your nutrition if you had beans without rice. And that's actually an outdated concept. So all protein sources can give you enough of what you need. And even vegetarian or vegan diets can contain adequate protein, provided they're balanced and you're getting quite a lot of some of the beans and nuts and seeds I mentioned earlier. And then plant-based diet can be really hard to understand. People often envision like all you can eat is lettuce or all you can eat are stalks of broccoli or something like that. And we know that for cancer risk reduction purposes, a plant-based diet is really just envisioning 2/3 of your plate or bowl are of plant origin, so like this picture shows above, and 1/3 or less of the meal is animal origin. So you can see here there's a really nice array of cooked vegetables, some what looks like quinoa, and then some cooked chicken breasts. So this would meet the plant-based diet category. A plant-based diet does not mean you can't have any animal products. So sometimes I'll give a whole lecture just on the gut microbiome, but we're going to go gut microbiome 101 today. And so what I love most in terms of a future reference is something that's called the American Gut Project, where they literally took thousands of people, had them do a diet recall. So they wrote down what they ate every single day, and they also turned in daily poop samples. And from that poop sample, they could see what kind of bacteria are in your gut microbiome. And if we were to sample all of us in this meeting right now, we would all have very different gut microbiome, what we call diversity. We'd have different bacteria. And one of the things that really influences what your gut microbiome diversity is actually how many different plant types you are eating. So to break it down, and the main takeaway here is that per week, people who ate 30 different plant types per week had a much more diverse gut microbiome than those who ate 10 or fewer plant types per week. Now, that can sound kind of overwhelming, but if you break that down and you even think about something like a salsa, if you've got tomatoes and onions and maybe a mango salsa, and you have some garlic in there, that's 4 different plants right there. If you have oatmeal, you add some chia seeds, flax seeds, blueberries, and maybe banana. Again, that's another 5. And that's just in one day, you're already at 10. So this idea isn't, again, that you have to go wild and only eat plants, but the idea here is that getting a lot of different plant types can really improve your gut microbiome. And as studies are showing, there's a lot of research with excitement about how a diverse microbiome can really influence the immunotherapy treatment. So it's interesting because that's often why fiber supplements don't have the same metabolic or microbiome effect. And so if you think about it, it's not to say don't take Metamucil if that helps you, but that's just one type of plant food. And so you still need the other 29. Okay, so the takeaway points for this section to break it down is yes, protein is important, but so is your entire diet. So the sum of all food and beverages you're ingesting. So cancer risk reduction, though, and in survivorship, we do want to start thinking about that plant-rich diet. So 2/3 of your plate is plant-based. Plant-rich diets and adequate protein diets don't conflict with each other. You can do both. And then don't skip the veggies and fruit for the protein-rich foods. Eat them all and eat them in balance. It's really important to us as dietitians, and I would say hopefully to all of you that we're enjoying what we're eating. It's one of the great pleasures in life is to really be able to sit down and enjoy the types of food you're eating. Okay, so we're going to jump in now to some food and diet questions and do some myth busting. So what about special diets? This could include things like intermittent fasting. Do I need to go keto, acid alkaline diets, and others? So most of these diets are the studies are very small, and there are not enough evidence to say that this is going to be helpful for any type of cancer or any type of, particularly for this symposium, kidney cancer. So beware of any diet or lifestyle program that's really encouraging you to purchase expensive supplements, special food, or equipment. What we do know is that the Mediterranean style of eating, which lines up really nicely with the American Institute of Cancer Research recommendations that we'll go into in a minute, is really what's recommended for both cancer prevention and survivorship. Okay, so this question, I would ask for a raise of hands, but I think I'd get all of you raising your hand. The question of, does sugar feed cancer? So if we think about what our bodies use for food, for our cells, all of our cells require glucose or sugar. So it is actually true that cancer cells do use sugar for energy, but so do all other cells in our body. And so it's not possible actually to selectively deprive our cancer cells of nutrients. And we know glucose is really important. Your brain actually uses glucose for fuel or sugar. So the best approach here is you don't have to fear carbohydrate intake. The best approach is to really minimize those insulin spikes or, thinking about like high blood sugar, thinking of it that way. So a balanced diet that includes carbohydrates is perfectly fine. And even better if you can tolerate it, to focus on whole grains, fruits, and vegetables and limiting the added sugars. That's what's really important. So if you can think about having a piece of fruit versus fruit juice, for example, that is the recommendation here. Okay, so I'm happy to take questions about this at the end as well. Now we're going to get into the last sort of the myth busting part is, should I avoid processed foods? Well, this is a hard one to answer because processed foods are really any food that's been changed for safety or convenience. This would include bagged salads, frozen vegetables, etc. So processed foods, that's not necessarily what you need to avoid or limit. But what we start to think about are the ultra processed foods. And these look more like when you look at a label, you have no idea what some of these ingredients are. And they're often bagged or packaged chips or things that you just know aren't really, you can't tell what food they actually came from. These are the types of foods that are more at risk or have products in them that aren't as healthy. And so we would say, choose products with a shorter ingredient list. You can recognize those ingredients. They have some fiber and they don't have a huge amount of added sugar. Any food can fit into a diet if they're on occasion. I would never stand up here as a dietitian and say there's absolutely no food you can't eat ever. That would be ridiculous and not consistent really with what we're trying to do. So I would say in general, have these on your eat on occasion list. And this is a statement that I'll just leave you with for this section, which is publicly available nutrition claims often exceed existing evidence. So if you really have a lot of questions or you're thinking, wow, this sounds really good, should I start this? This is when you can ask your medical team and they'll give you some guidance. And if there's more information that's needed, you certainly can be referred to a registered dietitian. So switching gears a little bit, let's just walk through supplements. This is a very true statement that I will read out loud just because it's very powerful. There is zero evidence that dietary supplements or natural products can prevent or cure cancer. We know that the FDA or Food and Drug Administration cannot legally regulate supplements. So there's also concern about purity or safety. The one thing I really do want to mention is that supplements can interfere with medication, chemotherapies, and immunotherapy. So it's very important to disclose your supplement use to your physician. And if you have questions about starting something new, make sure again that you're asking for advice. But I will say unequivocally, supplements do not prevent or cure cancer. They can often be very expensive, and some patients, a lot of people in this country, about 1 in 7 or 1 in 8, don't have enough money to buy food. So we really want to make sure that your dollars that you can use to buy the healthy fruits and vegetables, etc., are being well spent. In terms of supplements and cancer risk, to expound on that a little bit more, from the American Institute for Cancer Research, they really even have a statement as strong as do not use supplements for cancer prevention. Aim to meet your needs through diet alone, and they advise against the use of supplements as a protection against specific cancers. Now, I will say there are categories where people do need supplements. If you've had bariatric surgery, if you're deficient in a vitamin or mineral, or a drug is causing you to have low magnesium or something like this, possibly vitamin D here in the Northwest if you have a low level. There are reasons that you might need a supplement, but this should really be discussed and vetted through your care team. So quickly, I just want to say, hopefully these slides will be sent out, but it's important to know that there are some mechanisms by which you can ensure the supplement has had some testing and that it says on the ingredient list, if it has X, Y, and Z, that it actually has X, Y, and Z in there. So these are some labels you can look for, and this gives you a better sense that this is a reputable product, it's had third-party testing, and the ingredient list is actually valid. Oops, sorry, clicked too much. So keep in mind, though, the term natural doesn't always mean safe. So before taking any supplements, these are some questions that you would want to ask yourself, your care team, and just make sure again that your medical providers are aware of what you're taking. Okay, so I want to wrap up by really pulling it all together and let's just put science on your plate. This is what we love to do as dietitians. We're back here reading all the articles and understanding the guidelines, but what we want to do is translate it into, well, what should I actually be eating? So with that, saying it real clearly is that you can look on Google. Dr. TikTok is the new doctor in town. Nutrition recommendations seem to change weekly, but the basics honestly will always apply. What you can really latch onto here is that focus on adding more plant foods to your diet. And one of the statements that I love from our medical director at Fred Hutch one time said is, we want to be the best at getting better. So no one's perfect, but you can take a look, you can do a little reflection after the talk and think, wow, have I had any vegetables this week? If you haven't, that's okay. Maybe find one or two that you're going to add in. And for nutrition advice, generally speaking, if it sounds too good to be true, it probably is. So that would be a good time to double check your with your medical team what you should be doing actually. So I mentioned here, this is the blueprint for cancer prevention and also cancer survivorship. So I highlighted two of the key takeaways, which is a diet rich in whole grains, fruits, vegetables, beans, etc. And do not use supplements for cancer prevention. There's a lot of other things on here that we could go through if time allows, and there's some really great information on this website. So I have a link to it at the end of the presentation. The last two slides are really about foods that actually do fight cancer as part of a comprehensive diet plan. And these are very evidence-based. Again, it comes back to that theme of having a variety. I'm always quite thrilled to see on the bottom row, coffee is one of these foods. So there are some benefits of coffee. There's the garlic that I mentioned, and also you can get lots of good phytonutrients and polyphenols from tea. Here's your pulses and dried beans. So the idea here again is that we can be really diverse in our diet. You don't have to just only eat carrots or only eat one food. In fact, the evidence points away from that, and that the more variety you have, the better. So here in the end of my presentation are recommended resources, Here's the link to the American Institute for Cancer Research on top. We have a great website at Fred Hutch called Cook for Your Life that has a ton of great recipes. We have our website for patient education and a link to find a nutrition expert. So I think I covered it all in my time. And if time allows, I am more than happy to take questions. And well, I'll just stop there.
That was a wonderful tour de force. I always love this talk because I learned something and it helps me be a better counselor for my patients. We do have some great questions. One that was asked a couple times is, a lot of our kidney cancer patients have one kidney because they've had a kidney removed, and they're often told to avoid protein. Are some of your protein recommendations different when someone has one kidney?
That is a really great question. And generally speaking, no, we would just make sure that your kidney function is what we're looking at. So with that remaining kidney, and these are labs you can ask your doctor about, we would look at things like creatinine, urea nitrogen, glomerular filtration rate. We would really look at all of those factors to determine your nutrition recommendations. So this all stands. And Dr. Gore, if you have any thing to add here as the physician, but we would say the recommendations stand as long as your one kidney is working very well.
I agree. I often get asked about seeing a nephrologist, and we've had a nephrologist as part of this symposium in past years. And it really, as you said, it depends on what the function of the remaining kidney is. A lot of people have normal global renal function with only one kidney.
Can I add one? Sorry, I didn't mean to cut you off, but I wanted to say one thing we get a lot too is, do I have to follow what you call a renal diet? And the answer to that is definitely no, because that is very restrictive. And a renal diet would be for someone who might be potentially having chronic kidney disease at a high level or even being on dialysis. So if your kidney function is good, like Dr. Gore just corroborated, recommendations are the same.
Do you have any recommendations for sort of like a low irritability diet? One of the drugs we use a lot in kidney cancer called cabozantinib can cause a lot of GI irritation, and a patient may not want to exacerbate that with dietary things.
Absolutely. So what we have on one of the links that I put in for the Fred Hutch site is our patient education. And on that site, it's publicly available. You can find information. There's a handout that's called Diarrhea During Cancer Treatment, and it goes through a big column with more information on the try these than the avoid these list. Really quickly, what I'd say is that everyone is a little bit different, but high offenders can often be really spicy foods, really greasy foods. And if you're not used to eating a lot of fiber and you add a lot in all of a sudden, that can cause some gas, bloating, and loose stool. But again, people can be very varied in what their tolerance is. So this is where the individualized recommendations can really help.
We are at time. I want to thank you so much. I think we could probably do questions for the rest of time. But if you do have a moment, there are a couple questions in the chat. If you just have a moment to it'd be wonderful.
I'll just type them in and we'll go from there. Okay, well, thank you, everybody. Really appreciate you having me here today, and enjoy the rest of the time.
Thank you. Our last speaker of the day is Lindsey Moyer, who comes to us from Fred Hutch Philanthropy. We are in strange times for research, and one of our imperatives at the Cancer Center is impactful, groundbreaking, research that translates into innovations for patient care. So thank you, Lindsey, for being here this morning.
Yeah, thank you for having me. Everyone see my slides okay? Okay, great. Well, as Dr. Gore mentioned, my name is Lindsey Moyer, and I'm on the philanthropy team here at Fred Hutch Cancer Center. And I partner with physicians like Dr. Gore, Dr. Tykodi, and Dr. Tachiki to bring in funding from donors, community members, and patients that may want to support the research happening here at Fred Hutch. And I want to start by talking a little bit about what makes Fred Hutch so special. We are known for a leader in our cancer and infectious disease research and care. We have over 6,200 clinicians, scientists, and staff that work together to advance our research and compassionate care. Our focus on innovation goes back to 1975, when Fred Hutch led the development of the bone marrow transplantation to treat and ultimately cure many blood cancers and other diseases. Bone marrow transplantation offered the first clear proof that the immune system could be used for to overcome cancer, laying the groundwork for what would become the field of immunotherapy. Sorry about that. Words a little bit. Our belief in constantly improving the patient experience guides our science and still drives our approach today as we set ever higher standards of care. The same spirit that drives us continually improves treatments also drives us to ensure people don't just survive cancer, but thrive in the years after their diagnosis and treatment, and that most cancers are prevented before they even begin. This comprehensive approach and our experts' ability to work together to tackle cancer and infectious disease from every angle is made possible through generous support from folks like yourself, patients, partners, and donors who share our commitment to transforming cure and outcomes for all. In addition, those who also participate in clinical trials are instrumental in advancing scientific breakthroughs. We work with donors to understand their reasons for giving and to make the impact each finds most meaningful. Support provides us with the funding we need to plan for the future, follow the science and where it leads us, and be ready to drive new discoveries forward as quickly as they can.
And I want to share this quote from our president, Dr. Tom Lynch, where he says, "We never know which dollar is going to fuel the next transformational breakthrough. And that's why every donor and every gift matters so much." And as Dr. Gore mentioned, in this uncertain funding landscape, it is truer every day. And that brings me to the campaign for Fred Hutch, which you may have heard about. We are currently in the midst of it. This is a once-in-a-generation opportunity to galvanize our community in looking beyond what's possible. And our goal is to raise over $3 billion over 10 years. Our 50th anniversary last year gave the campaign momentum as we celebrated our community. And you may be asking what a comprehensive campaign is. It just means that every donor, every gift counts, no matter what specific initiative you'd like to support, and goes to support things like recruiting and retaining faculty, supporting research, and providing the space, resources, and facilities that we need to continue making discoveries. Funding can also be used to respond to greatest needs, funding gaps, and new program opportunities, along with strengthening support services for patients. Philanthropic support is more flexible than ever. There's many different ways you can give, and this allows our researchers to quickly follow where science leads, answer questions, and develop proof of concept for new ideas. So on this slide, there's just a few ways you can get involved with giving, from making outright gifts, giving through assets such as your stocks or retirement plans. And then we also have legacy giving, which folks are able to leave Fred Hutch as a beneficiary in their estate plans. Other ways to get involved include participating in a clinical trial, volunteering, or signing up for an upcoming event. I have some listed here on this slide. If you're inspired to make a gift in the coming months, Dr. Tykodi and the kidney cancer team are actually participating in a blood ride for the first time this year, which is coming up already next Saturday, August 8th, and there's still time to register if you'd like to participate. But if you would like to make a gift directly to Dr. Tykodi's work and the kidney cancer team, I have a QR code here on the screen that will direct you to that page. But if there are other priorities or pathways you're interested in learning more about, I'd be happy to talk further. Thank you for letting me present on behalf of Philanthropy. And just know I'm a resource here for you if you want to talk further. And thank you so much for the opportunity today.
Thank you so much. I appreciate you joining us today and sharing some of the really important messages about the role of philanthropy. Dr. Tykodi, do you want to give us some final thoughts?
Well, thank you, John. Thank you to all of our speakers from today's program and to all of our attendees for sharing your Saturday morning with us. And to remind you again, we do look at comments submitted almost every year. We're reacting to suggestions about topics from the year prior. So we really value that feedback and suggestions that people have for what things are of interest to you and of value to you. And, we anticipate carrying forward and having an ongoing annual program. So we'll be thinking about what we'll put together for next year once we wrap up from this year. And before we go, I just want to recognize Ritu Shriyan. Ritu, if you're still here, you could turn your camera on. Ritu is really the person that brings this program to life, does all the hard work for coordination and communication. So it wouldn't happen without her. So thank you to you for helping us to bring this forward once again. Ritu's been doing this with us for, 5 years now. It's been a bit. So hopefully we're getting good at it. So again, thank you, everybody. Appreciate the time this morning. And thank you, John, for being my co-host all these years.